Assalamu alaikum, peace be upon thee all. Welcome back again at the Emirates Center for Strategic Studies and Research, ECSSR, in our own second day of the conference of the Arab Health. Here for interventions for a healthier future. We'll have two sessions. The first one is entitled The Burden of Chronic Diseases, and the other one is the public campaign or mass media campaigns for tobacco cessations and effective mass media campaigns for public health. And we will conclude with some remarks and recommendations, and we start this second day with a speech by Mr. Tim Gable, Executive Vice President of Social, Statistical, and Environmental Sciences, RTI International, United States of America. Please, the floor is yours, Mr. Gable. The floor is yours.
Good morning. My name is Tim Gable. I'm from the Research Triangle Institute, RTI International. As was mentioned yesterday, RTI is a contract nonprofit research institute, and we're very excited to be here. It's a great honor for me to provide some opening comments this morning. Let me start by once again thanking the Emirates Center for Strategic Studies and Research and Dr. Al-Sawadi. It's a great thing to bring this many public health leaders from the region to a venue such as this. It's very visionary and forward-looking, and we thank them for allowing RTI to be part of this event. Yesterday, we heard many interesting and informative talks concerning cardiovascular disease and diabetes. These are global issues, of course, and very important issues here in the region. Dr. Ahmedma from Qatar University used the phrase multifaceted, and I like that phrase. This is a very complex issue and one that takes many people to understand. You know, there's no magic bullet or secret formula that will help us solve these issues, and so it's by working together that I think we need to come together and help turn the tide. We're living in a time when science is really moving quite rapidly, and we get frustrated, though, because these are such difficult challenges, and we can't move as quickly as science is moving to really solve the root problems and the core issues. Yesterday, His Excellency Sheikh Nahyan mentioned the words determination and persistence, and I think this is exactly what it's going to take in order for us to continue to push forward. The people of the Gulf, the people of the world, really need and deserve the quality of life. And so it's going to take all of us working together to make that possible. I heard yesterday in the comments that the Gulf region is lacking data sources for sort of region-wide information sources to help study the issues. And I certainly wholeheartedly agree with the recommendation that came forward yesterday that we should try to remedy that problem. But I do want to remind us all that we are living in this time of what's been called the big data tsunami. I mean, there's data everywhere. And so I think if we're clever and we're innovative in thinking about how to utilize data that are available in concert with traditional public health sorts of surveillance systems, whether it's from administrative records or insurance claims data or electronic medical information, I think we can try to make fast progress, at least in terms of getting some of the data resources together that can be shared and utilized. We're fortunate that we have tools, we have methods, we have a lot of talent in which to apply to this. But I really would say we also have a moral imperative to try to move fast. We heard yesterday, the problem is coming, the population is aging, the population is growing, and so I think now is the time that we really need to not only develop information, develop knowledge, but act on that knowledge. Yesterday I heard from one of our audience members that there are, in fact, strategic plans, there are action plans in place in many of the countries, but we have to implement those. And as we know, implementation is not easy. It's quite hard. Implementation touches individual people, it touches management systems, it touches all kinds of status quo inertia, and it's hard to move forward. And so, but I would put forward a challenge to all of us that now is the time and we need to force ourselves through breaking that inertia. So we have this sense of urgency, now is the time. And as we watch this problem unfold and we realize we're coming to a point where we must do something, I want to remind us of something that my colleague Jean Vieca said yesterday when she talked about implementation, and that was the power of celebration, and the power of celebration as an element to good implementation. We must find the points in which we have small successes and celebrate those successes, and that will help us build momentum. You know, I would love nothing more than to be standing here a decade from now, or even 2 decades from now, and all of us celebrating changes in those slides. The slides we saw yesterday with the trends going up, if we were sitting here celebrating, the trend has turned around, the trend is coming down. I think that would be a great moment. That would be a wonderful time. You can almost imagine this room full of people celebrating this accomplishment. And so I would ask as we go into today for us to think about how can we utilize the power of celebration and implementation to really push forward. So we've got this opportunity to make a difference. You know, those of us from RTI know that our mission statement is turning knowledge into practice. Improve the human condition by turning knowledge into practice. And I think that's the challenge that lays in front of us, is how do we turn the knowledge that we know? We know what causes cardiovascular disease. We know what causes diabetes. We know the issues. So now is the time to take action. Turn our knowledge into action. This is why RTI now has been in the region for 10 years. We're very thankful for our relationship with the higher colleges of technology and our new offices at their CERT facility, and we value their partnership, and I think we're so enjoying the relationships that we're building with many of you this week. And so today we're going to hear from some speakers and panelists. We're going to hear about the burden of chronic disease. We're also going to hear about the policies that can impact through mass media. And how can we utilize mass media? What is the role that mass media plays in changing behavior, sometimes for the better, sometimes for the worse? And how do we play to that reality and use it to our advantage? So I want to once again thank Dr. Al-Sawadi and his team here at the ECSSR. They've been so generous with pulling this event together and providing such a beautiful venue. I want to thank all of the moderators and the presenters and the panelists and the audience, those of you who have used your valuable time to come here and participate. I certainly want to thank my RTI colleagues and Mr. Mahoun Taha and the team that helped pull this together and has worked closely with ECSSR. I think we've all benefited from everyone's hard work. And so I look forward to the day when we are looking back on today and thinking about what a great beginning it was, and we're able to celebrate together the progress we've made. And so with that, I thank you for your time and attention, and we will start the program.
Thank you.
شكرا السيد تم على كلمتك.
اليوم الثاني بالجلسة الثالثة ويترأس سعادة الدكتور أمين حسين الأميري، وهذه الجلسة فيها مجموعة من المحاضرين يتحدثون عن مجموعة من القضايا ذات العلاقة بالأمراض المزمنة وتكاليفها في دول الخليج العربي. يسعدني دعوة الدكتور أمين حسين الأميري ليتفضل إلى الستيج، البروفيسور توماس هيرغرا. Yes, please, if you don't mind, can you come here? الدكتور خالد ربيعان، والدكتور محمد واصف عالم، والدكتور خالد خير الله.
بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Good morning to you, ladies and gentlemen, and it's my pleasure to be here with you at the second day of this very informative and very important conference discussing about the issues which really it brings a big burden on the countries. And as you know that economics is being considered a leading impact and element for the improvements of each single country worldwide. And therefore the burden which is taken into consideration by the different governments through the health authorities should be taken into consideration and should be discussed. And we have to gain from others' experiences and make sure that the best practice with the slight modification for each single country is very important for prevention and this type of care to be provided to different communities. Today, this session will be talking about the burden of the chronic diseases, and at the top of it is diabetes. This disease, it's not a selected disease for a single country, but it's a worldwide disease known to everyone worldwide. Today we have two eminent speakers. The first speaker is Professor Thomas Harger, and the second speaker is Professor Khalid Ali Arabian. It's my pleasure to present the first speaker, in which he will be talking about the cost-effectiveness model for diabetes. And I'm quite sure you know Professor Thomas Harger. He's a senior fellow at the RTI International, who is specialized in healthcare economics, public health, healthcare reform, and cost-effectiveness analysis. And he also has an extensive experience directing and managing health economics research. Dr. Thomas, you have the floor to talk about, please, the effectiveness model of the diabetes, and exactly you have 25 minutes.
Thank you very much for that nice invitation. There you go. Thank you very much for that nice invitation, and I would like to thank ECSSR for inviting me here. This is my second trip to the United Arab Emirates, and I'm very excited to visit your beautiful and rapidly changing country. One of the rapid changes has been the growth of chronic diseases, including diabetes. I'm an economist, so I'm going to be talking about both costs and benefits, and putting them together into what economists look at for health issues, cost-effectiveness analyses. I want to thank my co-authors and colleagues from RTI, and this work was done in collaboration with researchers from the Health Authority of Abu Dhabi. To give a little background, this diagram shows the prevalence of diabetes and the prevalence of impaired glucose tolerance in various countries and in the world. This is based on age-standardized data provided by the International Diabetes Federation, and shows estimates of what the prevalence of diabetes would be if every country in the world had the same distribution of population, including the same distribution across age groups. And this diagram is very simple. It shows diabetes prevalence on the horizontal axis. It shows impaired glucose tolerance on the vertical axis. Impaired glucose tolerance represents individuals who currently have high blood sugar but have not yet developed diabetes. So they are at high risk of developing diabetes. What you can see is one of the red dots represents the world, and you can see we know that the world is suffering from an epidemic of diabetes with relatively high prevalence and relatively high impaired glucose tolerance. In the United States, we have even higher prevalence of diabetes and higher prevalence of impaired glucose tolerance. and it's become one of the major health concerns in the United States. This is obviously very closely tied to the rise of obesity in the country. And then we look elsewhere. The other dots represent different countries in the Middle East, and you can see even higher rates of diabetes and impaired glucose tolerance. So we have a lot of people who already have diabetes and a lot of people who are at risk for developing diabetes. And so that's the basis of the paper, and the question is there anything we can do to try to prevent individuals from developing diabetes? Now, efforts in the United States to treat diabetes have evolved over the years. At first, the focus has been on persons with diabetes, really watching out and trying to prevent them from developing complications. And this has led to an emphasis on eye exams, foot exams, kidney monitoring, and other treatments for individuals who have cardiovascular disease to try to prevent heart attacks and strokes. The next phase of the evolution of care has really been to try to control the diabetes-related risk factors. And in the United States, we call them the ABCs, looking at A1C, which measures blood sugar levels, blood pressure, and cholesterol. And we have achieved successes in the United States for controlling these risk factors. Not everybody has their A1C under control, but the numbers who do have control has been increasing over the years, and the same with blood pressure, and especially with cholesterol. So we are achieving reductions in mortality rates for persons with diabetes. The problem is those gains for persons with diabetes have really been swamped by the rapid increase in the number of persons who have diabetes. So the prevalence of diabetes has doubled in the last 30 years in the United States. That's led to all kinds of costs and a new emphasis on trying to prevent the development of diabetes. That does raise a lot of questions. Can we really prevent or delay diabetes onset? Is it possible? How much does it cost? And is it worth it? Now, the last two questions are the questions that economists like to focus on, but obviously we need the physicians and the epidemiologists to answer the first question. As economists, we say, well, resources are limited, so we could spend those monies that we're spending on diabetes or diabetes prevention on other health concerns. So is it worth it doing that? RTI has been working with the U.S. Centers for Disease Control and Prevention to answer these questions in the United States. We have developed a mathematical simulation model of diabetes progression and costs to evaluate the cost-effectiveness of interventions to prevent diabetes and its complications. And over the years, we've published a number of articles that have looked at both persons with diabetes and persons at risk of developing diabetes. So we asked the question, could we use our diabetes model to look at the cost-effectiveness of diabetes prevention in Abu Dhabi and possibly in other areas in the Arabian Gulf? So it's a very complicated mathematical model that's programmed in a language called C++. I won't bore you with the details, but basically this gives a really brief synopsis of the model. There are different individuals with prediabetes. They can develop over time diabetes. If you have diabetes, you can develop the complications of nephropathy, neuropathy, retinopathy, coronary heart disease, and stroke. Nephropathy leads to kidney disease, which in its extreme case can lead to end-stage renal disease, which can often be fatal. Neuropathy represents problems with nerves, nerve damage that can lead to foot ulcers and lower extremity amputations. Retinopathy can lead to blindness. Coronary heart disease can lead to heart attacks, and stroke can also cause fatalities. So the model represents, along these lines, these arrows, transition probabilities between states, and we put interventions that can potentially slow these interventions. Slow these transition probabilities. The model simulates disease complications, mortality, costs, quality-adjusted life years, which correct for both the mortality and morbidity, incremental cost-effectiveness ratios, and the progression of persons with prediabetes until death or age 95. So it's a simulation model that looks at all those issues. We were able to collaborate with people from the Health Authority of Abu Dhabi. They provided health statistics, population, and mortality tables. We were able to obtain a subset, the cardiovascular disease subset that HOD has collected for the years 2009 to 2012 that looks at persons at risk for cardiovascular disease and gives us resource use, disease codes, and costs. We also obtained data from the WICAIA, a population-wide cardiovascular disease screening program that gives us information on individuals with prediabetes. So this table gives us a list of the data sources. You can see that the main data sources that we're using for diabetes progression are from the United States and the United Kingdom. The United Kingdom conducted the United Kingdom Prospective Diabetes Studies that provides some of the best data on progression to complications. For diabetes complication costs, treatment costs, and prediabetes prevalence and risk factors, we use data from Abu Dhabi. For the intervention, we'll talk about the assumptions that we use on effectiveness and resources that come from the United States, and the costs of visits come from Abu Dhabi. We also use a probability of diabetes onset of 3.8% annually. That comes from US data, and the data on quality of life for different conditions comes from the United States. So this gives a table that shows the estimated costs of diabetes complications and treatment in Abu Dhabi. These are costs that are calculated in 2010 Emirati dirham and converted to US dollars. We have both one-time costs that represent the costs in the first year of the disease for different conditions, and we have annual costs that represent the ongoing costs in year 2 and later for individuals who have this complication. We also include an average treatment cost of about $1,572 based on drug costs and the number of visits that individuals with diabetes face. So when you do cost-effectiveness analyses, you have to look at what would happen with an intervention and what would happen without an intervention. The intervention that we look at is based on, and this is a potential intervention, based on the United States Diabetes Prevention Program. And that consisted of an intensive lifestyle intervention that included diabetes education. It included targets for weight loss and exercise. So the target for weight loss was about 7% of body weight, and the exercise target was about 150 minutes per week. This was a 2.8-year trial, and people were examined, and there was a 58% risk reduction in the probability of diabetes onset. The individuals that were looked at were individuals who had both impaired glucose tolerance and elevated levels of fasting glucose. So they had pretty high rates of diabetes onset in the absence of the intervention, but the 58% risk reduction and an average weight loss of 5.6 kilograms. And it turns out that weight was the biggest determinant in risk reduction. To turn that into an analysis for the United Arab Emirates, or for Abu Dhabi, we focused on UAE nationals with prediabetes aged 25 to 74. We assumed that the risk reduction in intervention costs were maintained for the rest of their lifetime, and we used costs based on 16 visits in year 1 and 8 visits in subsequent years, where the cost of visit was based on the cost of a physician visit in Abu Dhabi. So this table shows our simulated results. The top solid line shows what is simulated to happen with no prevention. And you can see that over the course of the lifetime, with a 3.8% annual incidence of diabetes, nearly 70% of the persons would develop diabetes. If we look at the lower solid line, which represents diabetes prevention, we can see a fairly substantial reduction in diabetes over time. And there's two ways to look at this. If we look at the course of the lifetime, so we look at the top results, we see about 28% fewer individuals developing diabetes. So you can think of that as diabetes prevention. If we look at a given level of cumulative incidence, say 30%, we can look at the difference horizontally between the no prevention and the diabetes prevention line, and we see about a 15-year delay at the 30% level. So whether you want to think of this as delaying diabetes or preventing diabetes, you can see a pretty substantial effect for this potential intervention. Okay, those are the results for diabetes onset. This is the results for cost effectiveness. You can see that for the treatment costs, we see a pretty substantial reduction of about $6,000 per person in treatment costs. We see a reduction in complication costs, but interventions do cost money. In this case, we see an intervention cost increasing by about $8,000. That's the cost of providing this continuing diabetes education over time. So overall, we have a result where total costs increase by about $1,600 per person. So costs do go up, which we would prefer that they went down, but that's what we find. If we look at the bottom side of things, the bottom rows, we can see the changes in life years and the changes in quality-adjusted life years. In this case, the quality-adjusted life years are discounted to represent the fact that they occur in the future. So we see that life years are increased by about 0.76 life years per person. Quality's increased by nearly the same amount. And the overall cost-effectiveness ratio is in the lower right, which is the cost per quality of about $2,337 per quality. Well, what does that mean? What does the cost-effectiveness ratio mean? Most health interventions actually increase costs and improve qualities, leading to a positive cost-effectiveness ratio. So if we're treating an individual with a heart attack, we're going to want to treat that individual, even though the cost of treatment is high and is higher than if we just left the individual untreated. So most cases of health care lead to this positive cost-effectiveness ratio. It's very rare that we have the case where a health intervention actually leads to lower costs and improved quality-adjusted life years. So we don't have that case, but we do have the case where we have a positive value of about $2,000 per quality. Well, again, is that good or is that bad? Well, the World Health Organization has issued general guidelines for cost-effectiveness analyses, and they say that if you have a cost per quality less than 1 times GDP per capita, that intervention could be ruled as highly cost-effective. If it costs 1 to 3 times GDP per capita, that would just be plain cost-effective. And if it's greater than 3 times GDP per capita, it's not cost-effective. Now, in 2011, the Abu Dhabi per capita GDP was about $49,000 per person. So compared to that, we would conclude that diabetes prevention is likely to be highly cost-effective. As economists, we do a bunch of sensitivity analyses to see if our results are robust to our assumptions. I won't go through all these, but it shows the cost per quality is still going to be generally considered highly cost-effective, and in some cases, it may actually be cost-saving. So, as economists, we also want to mention our limitation. The progression is based on US and UK epidemiological data. So we can ask the question, is progression different in the Arabian Gulf? And I'll leave that to other members of the panel to discuss. And the next two questions I'll discuss in the next couple of slides. But I will say our model can be updated to incorporate new country-specific data as they become available. So that leaves the question, this is a simulation, and in fact it's a simulation of a program that has not been rigorously tested in the Arabian Gulf. So the question is, can diabetes prevention be successful in the Arabian Gulf? Well, the first thing we can do is look at the literature. The literature says there have been 5 major studies of diabetes prevention in India, Japan, China, United States, and Finland. Those have shown risk reductions ranging from 25% to over 60%. And perhaps most impressively, in China, the program has been conducted for 20 years and has produced a risk reduction of over almost 50%. So this does suggest that in a variety of cultures, diabetes prevention can be successful. Still, designing a successful program will be challenging, I think, in the Gulf states. Can we design a culture-appropriate diabetes education program? Can we go for a weight loss target of greater than 7% of body weight? That is, can we get individuals to participate, and will they lose 5.6 kilograms per person? Can we maintain or try to maintain this exercise target of 150 minutes per week? If it's a 24-session program, which is what it was in the United States in the first year, will people be willing to attend that kind of a program? And then finally, can the weight loss be maintained? So these are actually a question I'm not going to answer. I will look forward to talking to you about what the answers are to these questions. But in conclusion, cost-effectiveness models like this can inform policy decisions about prevention. The results indicate that diabetes prevention has the potential to improve health and lower healthcare costs in Abu Dhabi. Similar analyses can be performed for other countries in the Arabian Gulf, and we have these key remaining questions that hopefully we can talk about during the panel. So thank you very much for your time and attention, and I look forward to talking more.
Thank you, Dr. Thomas. Thank you very much.
Dr. Thomas,
at the end of this session, and if you'll allow me to present our second speaker for this session, is Dr. Khalid Ali Al-Rubayyan. He is director of the University of Diabetes Center in King Saud University, and he's also working as a consultant endocrinologist and associate professor, College of Medicine at King Saud University. And it's our pleasure to have Professor Khalid with us to talk about the diabetes in the Kingdom of Saudi Arabia and its economic impacts. Dr. Khalid.
Bismillah wa salatu wassalam ala Rasulullah. Dear colleagues, it's really a great pleasure for me to be with you this morning after a tough trip. But finally I made it. I think in the beginning I'm really very pleased because I think I'm talking to the right people in the right place for the right sake. And it's really a pleasure for me to really highlight and use Saudi Arabia as an example to show you how much we are really bombarded with chronic diseases. In the beginning, I think the Emirates Center for Strategic Studies and Research is really should be given the credit of adopting such programs because I think this is what is going to face the Gulf states. During my talk, I'm going to give you a very brief idea about the extent of the problem in the Gulf states, but then I will focus mainly in Saudi Arabia because most of the data available for me at least, and also in the literature are from Saudi Arabia. I'm going to speak about a big epidemiological study which has been conducted. At the same time, I'm going to give you data from more than 150,000 diabetic patients in our National Diabetes Registry, which will give you even better, more sensitive data that can be, in fact, simulated and also used because I think what is happening in Saudi Arabia is going to happen in Emirates, if not has happened already. I think the first slide I would like to start with is basically giving you an idea about the epidemiological aspects, and then I'll go to the medical aspects, and then social aspects, and then I'll go to the economical aspects. I'll try to utilize my time quickly, but this is 25 studies which has been done in the Gulf states, and as you can see from Saudi Arabia, Kuwait, Bahrain, Qatar, and Emirates, and also Oman. And this is over almost more than 30 years. You can see starting from the early 80s until almost now. Those are different studies. I know that the criteria has been different, the diagnosis has been different, the methodology is different, but at least it gives us the clue. Now, if you try to draw the trend of diabetes in the Gulf states, it's really very clearly going up. And it is going up in a rate of almost 1% per year, which means every 10 years we will have another 10%. Now, the only thing which is really very interesting, when we went deep and used our biostatisticians to try to analyze, are we different in Saudi Arabia from Emirates and from Oman and Kuwait? In fact, it was really amazing to see that there is a difference. The worst is seen in Saudi Arabia, and as you can see, the trend is going very sharply up, followed by the other trend, which is the Emirate trend, you can call it. But there is a very interesting trend, which is Omani's trend. And this is to answer my colleagues in the first talk, is there anything which will hint that prevention programs can do? I can tell you that Omanis have adopted some prevention programs, and this has been reflecting very clearly, in fact, in the outcome. And I think part of them staying at this level may be because of such adoptions and such programs. Now, this is what is happening at three levels. I think Emirates, in 5 years' time, I think they are going to follow the same trend Saudi Arabia is really following, unfortunately, if no prevention programs will be started. This is for diabetes per se. Now, let me tell you what will happen with impaired glucose tolerance or impaired fasting glucose tolerance, which is the pre-diabetic phase. Again, we have exactly the same trend also. When you look into the data from Saudi Arabia and try to compare it with the other Gulf states, you can see again another two trends. Saudi Arabia is leading everybody with the upgoing curve, as you can see, and Emirates, I think, is almost going to follow the same rate if no prevention programs or if no programs has been focused on those pre-diabetic patients done immediately to really stop the invasion of this big medical problem to the Gulf states. Now, to convince you more, this is our data from what is going to be published maybe in a few weeks or months from now. This is our big national diabetes study, and this shows you the different risk factors. Look at the prevalence of diabetes in men and women with age, and you can see that we are speaking about 1/4 of the population who are older than 30 are by definition now diabetic. And unfortunately, another 1/4 who are also in the same age group are pre-diabetic or impaired glucose tolerant. This is using the new criteria and using fasting blood sugar. The other very interesting point is this, what you can see for the impaired glucose tolerance, which is the pre-diabetic phase. Look at this, there is no age preference here. which is somehow very strange. And I can tell you that this is because of the change in our lifestyle and the invasion of another big risk factor, which is the obesity. And this is why we are seeing impaired glucose tolerance in women and men, regardless of their age pattern, which is something telling us that this problem is going to grow and grow even in the future if nothing has been done. This is only a regression analysis looking into the odds ratio and relative risk values, trying to come up with the major risk factors for both diabetes in the top here and impaired glucose tolerance in the bottom. I just want you to know that the risk factors for diabetes is mainly age, hypertension, previous history of gestational diabetes, and hyperlipidemia, mainly hypertriglyceridemia. And as you can see, that they have really exceeded 2. While the other risk factors, which are really considered in the Caucasian population more important, is less important in our situation. I think this is, again, for different reasons, which I'm going to really allude into. Now, if you separate diabetic patients and look into the pre-diabetic population, then you are really going to be exposed, you will be exposed to another risk groups. Previous history of gestational diabetes, dyslipidemia, obesity, high triglyceride, and big babies, and so on. They are almost affecting our population in a similar manner. What does this mean? This means that, unfortunately, as we are aging, and I'm very pleased that the first talk was speaking about the aging process going on in our Gulf states. 50% of our population are less than 20, but believe me, we are now having more and more middle-aged and old age than before. This is going to be really reflected very clearly on the disease prevalence in every 10 years, and this could really explain why we are really stepping up very sharply. Now, I have to give you a very brief idea about the epigenetics, which is the genes and the epidemiology. And I was having a discussion this morning, which one is more important in our society? I just want to tell you that both are important. And unfortunately, because of our high consanguinity rate and because of our familial aggregation, this have really made genetics here more important than what we see in China or even in the Caucasian population. Now, if you are going to adopt prevention programs, then think about the changeable factors. Let us work hard on diet, drugs, obesity, smoking, hypertension, dyslipidemia, and physical activity. I know that we cannot do a lot on this other than trying to really educate people about certain social and cultural habits, but believe me, we cannot change our gene, and we may be resisted when we come to the culture trying to reduce the rate of consanguinity among our cultures. Now, I'll give you 2 examples. This is the first example. This is the study which we have done, where we have analyzed all the genes which has been adopted by different genetic studies, looking into the Arabs as an ethnic group and trying to compare them with the Caucasian. I think you would agree with me that there is a very unique 2 groups, and this could really explain to some extent that, yes, we do have the gene that really predisposes us more than other cultures when it comes to impaired glucose tolerance or even reaching to the phase of type 2 diabetes. And this is a strong clue that this could be another factor. A second factor is obesity. You have to know that obesity in this part of the world is growing faster than anywhere else. We are talking about obesity in 20 years back, which did not really touch 20%. Now we are speaking about 60%. And this is a huge increment that has happened. And this is from the same data and some studies which was done in the Gulf states. And as you can see, unfortunately, we are really exceeding now 50% of our population being either overweight or already obese, unfortunately. Now, what really makes things worse is another issue, which is the obesity among children as a predisposing factor for type 2 diabetes in the near future. You have to know that in Saudi Arabia, now we have the highest obesity among children. When you look into this Lancet paper, which was published in 2002, you can see in Saudi Arabia we are 6.3, and the second highest was in Egypt, 3.9, and another one in Morocco, you can see it is 3.8. So it seems that we are also ethnically more prone to develop obesity at a younger age. This means that we are cooking the disease in the future. This is, I think, enough data to tell you how much this problem is growing in the area, and I'm using Saudi Arabia as an example. Now, let us forget about the spread of the disease and let us go deep into the disease and see, are we different from what is happening in the whole globe when it comes to the complications and the aspects of the disease? The first things I would like to tell you that unfortunately, if you look into the different studies which was done in the United States or in UK, for example, and compare them with all the data which are available in the literature from Saudi Arabia, unfortunately, we have the highest fasting blood sugar and even the worst 2 hours postprandial. What does this mean? This means that for each millimole, since we are 10 and they are 8 or even 9, this means that we have about 25% more chance of having complications than what they have there. And this is just only because we are a little bit lousy when it comes to controlling diabetes. This is a very important point before we go into the complications. Now, this is not to say that when we did our community survey, we catch diabetic patients. And part of our survey was to see how good they have been controlled. And you can see another shocking data, 65% of the people whom we catch them in the community, known to be diabetic, unfortunately having a hemoglobin A1C more than 9, which are by definition poor control. And only 25% were really on the range. So this tells you how much the problem within the diabetic population also. This is a very well-known graph showing you the correlation between the hemoglobin A1C and the different complications, the retinopathy, the nephropathy, the neuropathy, and the microalbuminuria. And to implement this graph, which is a standard graph, you can see that we are really having very big problems. 75% more than 90, 15% between 7 and 9, and hemoglobin A1C, and only 10% who are really less than 10. What does this mean? This means that within only 10 years, with that level, we are going to have a huge bombardment of the chronic complications among our diabetic cohort. Now, let us see what is happening now. And this is the data which we have gathered and published 2 years back, where we have looked into all the data available from different complications. You can see the highest complication was the dental complication, followed by neuropathy, retinopathy, cataract, impotence, hypoglycemia, ischemic heart disease, and so on, up to cerebrovascular accident. Now, this means that we do have a huge population. At the same time, unfortunately, they are not really reaching up to the optimal control, and this will base all these very high prevalence rate of complications. Now, where is the problem? So I thought, let me give you an idea of certain, I will just catch examples like disability or morbidity. Now, if you look into the age grouping and look into amputation and the stroke, you can see we have really quite large collection of people, unfortunately, as early as 45 years of age. And we do have ischemic heart disease less than 30, and people who have stroked on the 50s, and so on and so forth. This is, again, something which will also exhaust economically and socially and also medically. Now, if you go deep and try to see who is really monitoring those diabetic population, you will be seeing from this graph that almost more than 80%, in fact 85%, are really controlled by primary care doctors or private primary care doctors or hospitals. So the highly specialized entities, either internists or diabetologists, are only seeing a very small piece of those population. This tells us very clearly, and I think I have to tell you in Emirates and also in all Gulf states, if you want to work hard and you want to stop this disease and its really devastating complications, go to the primary care. This is where the money is, and spend more money there, because this is where the population are really located. Now, this is just to give you an idea about the same things, but let me give you another example. This is from our registry. What we did here, we took about 84 per 1,000 patients from our registry, and we scanned them and we evaluated them for eye examination. Look at this. Only less than 30% of them have had an eye examination, unfortunately. This is again for the same problem. They are mainly seen by the primary care center. Those who have has an eye exam, look at them. Also, again, 1/3 of them have a disease. And those who have proliferative problem, also 1/3 of them have a disease. And those who needed laser, only 70%, another 30% didn't have the laser, although they need the laser. Now, I want you to imagine that there are people here and here and here who will need laser because they have proliferative disease. And this is why we have very high incidence. Now, diabetes is the leading cause of blindness in the Kingdom of Saudi Arabia. Now, what we did, in fact, here is to look into the economical point before we go into the cost of the disease. And during the questionnaires, which was really spread to the patients, we asked them from where you got your management, to where you go and have your treatment, and who's supporting you. I just want to tell you that the whole formula is upside down. We have only 1.8 insured, 5.7 they support themselves of the cost, and 92 is done by the government. I think there has to be something to be done so we can flip it again. We should really encourage the insurance, because this will improve the quality, improve the screening, improve most of the things, and I'm sure they can do a lot of reduction in the disease. Now, what are the public aspects? I think what I should share with you is this very nice graph which was produced by the World Bank. And this is the consumption, dietary consumption over the years, and the yellow is the average for the whole world. And this is the developing country, the developing countries. You can see their consumption is low. And this is the industrial countries. You can see they were leading everybody until low-fat diet start program. And you can see how sharply they are really following a very nice trend. Now, where are we in the Gulf states? We are here, unfortunately. This is the GCC countries. We are leading everybody when it comes to the total consumption of diet. Now, keep this in mind, and keep also the other issues, which is education. And I don't think I need to go into any further point. Unfortunately, we need to do a lot of mass education, community education, individual education, patient education, not only for the patient sometimes, but also to the health personnel, to try to really encourage them to do more and more on this. We shouldn't be a prescriber. We should be we should promote education within our community. This is just to show you how much exercise is being done at the community level, and if they were following any diet, and this tells you that we need to do a lot, because unfortunately the percentage is still low and low. Now, there is a social part of disease in this part of the world. I haven't seen it when I was in North America, but I can tell you we do have a stigma. Diabetes is a stigma in our culture. I don't know why, but it's still. There is a problem in the work and with the sick leaves. Marriage is an issue. It's a big issue, in fact, especially ladies. And we have to do a lot of education to try to come up with this social disability is an issue also. And as I told you, Unfortunately, the mean age for Saudi diabetic patients is almost 13 years younger than the non-diabetic. And this is again from our registry, which is also a very important point. Now, we do have certain beliefs that we can use them. There are cultural beliefs and there is religious beliefs and impacts that we can use them to really stimulate the education and prevention programs, and also utilize some personal experience. This is beside my house in Aroda in Riyadh, the capital of Saudi Arabia. This was not there, I can tell you, 5 years ago. And now you can see people are really walking, which is really something encouraging. And I think we have to have more and more of such things. Now, my last part will be about the economy. Although it's very short, but I have condensated the slides just to give you the message how much this disease is really costing the kingdom. I want to tell you that from our survey, we were able to drag out from diabetic patients how much they have been admitted, where they have been admitted, what type of treatment they have used, and so on and so forth. Our major problem is calculating the real cost of this issue. And this is something I think you people have to also start standardizing the cost for any services given to, not only for diabetic patients, but for all chronic diseases. What we did in the Strategic Center for Diabetes Research, what we did, in fact, we called different private sectors and we collected data and we averaged the cost. And this is the data which I would like to share with you. The kingdom is really, the diabetes is really costing the kingdom almost 100 billion Saudi riyal. Out of this, 12 billion is direct cost and another 88 billion non-direct. I will not touch the non-direct because it's a very complicated issue, but I'll show you some of the data from the direct cost. You can see that this is the overall cost, but big chunk of it is really coming from the hospital care. I think if we work hard on education and prevention, this much of spent is going to decrease slowly, and we are going to be in a better shape. Now, look at the drug supply, about 1 billion, another 1 billion, 300 million for foot care, another dental care is costing almost 1 billion, $500 million for dialysis, and so on and so forth. This is when you spread them into type 1 diabetes versus type 2 diabetes, which is the childhood diabetes and adulthood diabetes. You can see that the majority is type 2 diabetes. And I'll tell you why. Because the complication is high among them, and they are high in number. We do not have a big problem with type 1 diabetes. It is increasing with time, but I can tell you, number-wise, the more than 80% of our diabetic population are type 2 diabetes. Now, I would share with my colleagues who have just spoke about the change from the time you've been diagnosed with impaired glucose tolerant to the time when you develop ischemic heart disease, cost-wise. And this is the study which was published in Diabetes Care, which is really very sensitive and beautifully designed. Look at this. From the time the patient has been found to be pre-diabetic to the time he will be diabetic with the complications, you can multiply his cost by almost 3 times. You can prevent all this by secondary prevention and primary prevention. Where we should put our money? I think we have 4 levels. We have the community level, the patient's level, the health system level, and the doctor's level. Now, I want to tell you that in the community, we are going to work on the primary prevention, community education, risk factor reduction, and different sectors' involvement. At the patient level, we have to screen them because you have to catch them early and you have to manage them early. And here you have to catch the persons who are at risk, medical checkup, and periodical examination. Now, for the health system, we are going to work mainly on the secondary prevention, preventing retinopathy, nephropathy, neuropathy, and vasculopathy. And for the doctors, we are going to train our doctors and produce guidelines and do a lot of research and so on. Now, I want you just to concentrate on the next slide because it will tell you where you should put your money. This, as you go up, this is very effective, less cost. And as you go down, you are going to spend more money and your effect is going to be limited. I want to tell you, I strongly believe in Saudi Arabia and also other Gulf states, we are spending a lot of money at this level. We are spending a lot of money, but we are not seeing a lot of effect. Now, to give you an idea, from a scientific publications, an accurate data, I would like to tell you that the cost per person per year for the community is about 3,000 every 3 years, versus 8,000 if you want to prevent the complications per year, versus 25,000 per year if you are going to spend your time on the doctors and these big fancy hospitals. I think my last slide is speaking for itself. 1/4 of the Saudi population are diabetic, another quarter are pre-diabetic, 10% of the population will be affected in 10 years, 1/3 of the population are by now having retinopathy, 10% of them are legally blind because of diabetes, 1/3 of diabetics have nephropathy, and 1% of them are on dialysis. 1/4 of diabetic patients will develop ischemic heart disease during their life. 10% of our diabetic population are dying every year, which is really alarming point. And this is from our 150,000 registered patients. But look at this. We are spending 20% of our real budget, health budgets, only for diabetes. Thank you very much.
Thank you, Professor Khalid. Thank you very much for a very informative speech. And although it is a warning, data and informations, but I think it's very important for the decision makers and the countries to understand those data and to be able to take action for the proper prevention. Ladies and gentlemen, allow me now to go to the third part of the session. The third part of the session is the rule of the panel discussion. We will take around 40 minutes, and the most important issue for me is that to have the sort of intervention and the interaction from the audience here, because your feedback, your comments, your suggestions probably will be very helpful in coming up with the nice recommendations which it should be taken into consideration by different participants and also the governments. And I'm quite sure that the outcome or the conclusion, the recommendation of this very informative conference should be distributed through the Executive Office of the Saudi Arabia, of the GCC Council in Saudi Arabia, to the GCC countries that they could be benefiting from this very informative recommendations. Ladies and gentlemen, allow me to introduce you the two gentlemen we have here, which they will lead the panel discussion here. The first one is Dr. Muhammad Wasif Alam. Dr. Muhammad Wasif Alam is a US-trained physician with a doctorate in medicine and master of the science in public health. And also, it's the pleasure to introduce Dr. Khalid Khairallah. Dr. Khalid graduated from Jordan University of Science and Technology with a Bachelor of Dental Surgery and Master in Public Health. Please, the floor is yours for the panel discussion.
Thank you very much. I have to appreciate and thanks to the organizers for this wonderful conference with all the top leaders in diabetic who are here in this conference. I am really thankful to the audience and also being here. And I'm fortunate to be here myself. Diabetic, as you know, and we have heard and we believe is an issue, is a problem around the world, and more so in this part of the world. We understand how big the problem is. We understand how much it costs. We understand everything. But the problem is, I believe, how much are we doing? what are the things that needs to be done is being done. We have all the regulations and all the declarations. Yesterday evening, I was just browsing the internet and I wanted to see how many resolutions we had on diabetes in the region. I'm going to share with you some of them. We had in World Health Assembly Resolution 2004, 2008. Then we had a United Nations Resolution 2006, 2011. Then we had the MENA Diabetic Leadership Forum, Dubai Declaration 2010. Then we have a joint statement of health ministers, GCC 2007 and 2008. Then we Riyadh Declaration on Diabetes Economics in 2007. Then we have an integrated Gulf Executive Plan for Diabetes in 2018, which is the plan. Then we have Doha Declaration on Diabetes in 2009. Then we have Jeddah Declaration on Diabetes in 2010. And you name it. These are some of the ones that I thought picked up, and then I'm looking at it. Hey, I'm being a public health guy. Have I really looked into those declarations? To be honest, I have not. So I think we need someone, maybe we need a PhD student to go into all those declarations and see what is inside those declarations that ask us to do, and then see what is lacking, what is that we are not doing. Because I'm pretty sure all the declarations are talks good. How we can manage, how we can reduce, how big is the problem, how much does this cost, whether this is cost effective or not. We are in this part of the world, alhamdulillah, where GDP per capita is amongst the highest in the world. So I don't believe that cost can be a great challenge. If we have the wish with the will, I think we can do it. We have seen all the cost, benefit ratios, and we've seen the GDP per capita and the cost of diabetes is very nominal for this part of the world, and we are lucky, we are fortunate. And we have now, you can ask me now, okay, what are you going to do? We don't want to reinvent the wheel. We don't want to do more research and see, how big is the problem, and which age, which population, and all those things. I think we'll be wasting more of our time doing it. We need to act now, and it has been shown repeatedly the things that has worked are three things, basically, three things. One is the awareness, education. Two is the weight reduction. And three is the exercise. So if you ask me which one you want to pick, you want to do all three? Perhaps, yes, if I can do it. But I would say the best buy to do the diabetic right now, if you want to jump on it tomorrow, is to look into the weight reduction. Because that is not only for diabetes, it covers many other non-communicable diseases at the same time. Now, weight reduction, of course, has two important factors. One is dependent on our tongue, our taste buds. We enjoy food that is not good for health. I mean, that's something that I always say, that everything that tastes good is bad for health. Everything that tastes bad is good for health. So it's very difficult to train my taste buds, hey, don't eat this when I have so many things available in the market. What I think is more feasible to do is exercise. I will not say that don't check your diet. You better do it. But what is, I think, more encouraging and more rewarding is to reduce our weight. And it has been shown in the previous speaker that is the best buy for reducing diabetes, reduce the risk by 60% or so. I was amazed, wow, 60% of the risk factors for diabetes is controlled by reducing weight by 7%. Nothing can be better than this. So weight reduction, I think, is the key. And we have seen in this part of the world how big is the problem. We are in the top of the world in terms of obesity and overweight. Now, you're going to ask me, okay, so what are you going to do as a public health guy? What are you supposed to do? How are you going to reduce the weight? exercise, of course. I think we need to touch the schools. And I think this is our key element, the key target group, the school children. I come from US, and I have seen almost all the part of the world in different parts of the world. And I've been fortunate to be in the Gulf countries for many years, more than 12 years. And what I have seen that in the school, and of course in the adult population also, people love sports, which is good. But I have not seen people love any other sport besides soccer, which is football. So why we all into one sport only, where there are so many numerous sports in the world that people enjoy? And again, the women the female don't play football. So what are we doing with the female? How can we encourage more sports in our community, more sports in the schools? We can encourage and give them incentives. Yesterday, some speaker was talking about what is the incentive. We have to really think about incentives. We have to give reward for people who do exercise, people who engage themselves in sports, and people, should be in the school curriculum to be involved in physical activities. So I think these are the key elements that I think are lacking, that we have to take control. Thank you very much.
Thank you, Dr. Mohammed. Can we have your input, Dr. Khalid?
Assalamu alaikum, and thank you for the comments. We just drove yesterday, and we talked about it, and he was so enthusiastic to talk about this, about sports especially. First, I would like to thank the Emirates Center, the RTI International, for having me here. I'm from Jordan. Apparently, I'm the only guy presenting some of my experience from Jordan. Where I come from the academia. I will start with what Mr. Tim said, then what Dr. Thompson and then Dr. Khalid talked about. The first thing was the need for some surveillance. There is no surveillance in the Gulf states. And then building a cost-effectiveness model based on US and the UK data. And then all of a sudden we have that big, massive data presentation that was so interesting to further look into and see how these numbers came up, where did they come up, can we use them for a public health intervention? Can we use them to build a program for diabetes? Can we use them to build a program for risk factors? I think, I'm not sure, Dr. Khalid, but I think most of the data came from multiple studies through different time periods, which raises the question, do we have a baseline data to look into? In Jordan, we have the behavioral risk factor surveillance system. It's a survey conducted every 3 or 4 years, a very good source of information. It has a lot of data. It does not have information because it's a data set sitting on somebody's office, and it takes you time to access the data, but we do not really obtain information from it because in most of our field, we are data rich, information poor. We collect data everywhere. The thing is, we have no process of converting the data into information. So the first line will be to conduct a survey and see the baseline data where we stand, convert the data into information, and see if we can change the behavior, what to change, what's the simple thing to change. In public health, knowing is not doing. We all had a discussion about the food and junk food yesterday, but we went and all had the chocolate dessert for dinner. So knowing is not actually doing. So starting with some baseline data, we still can answer the question for the cost effectiveness. We can tell who to target. We're going to go hit the community. We're going to hit the patients in hospitals. Do we going to hit youth, early adults, kids, pregnant women? This is all will be based on baseline surveillance data that we can use. The good thing is you only need to collect the data every 2 or 3 years, and it's risk factor data. You need to collect data about the behavioral aspect of the disease, what hits the disease. So it's maybe it's one surveillance system, but it answers all your questions. You can collect data about diabetes, risk factors for diabetes. You can collect about tobacco, heart diseases, physical activity. All these are in one survey. One of the research question I've been trying to investigate is religion and public health and diabetes, religion and tobacco. It's interesting. Religion has to do with our behavior. It has to do with diabetes. It has to do with our healthy lifestyles. Now, how can we incorporate religious public health intervention into this field? I don't know. I have no real answer to this. An experience in Jordan, just like anywhere else, we talk about policies, intervention, conferences. We have a couple of medical students who are enthusiastic to go and do something. We let them do something. We let them go to schools and play with kids and introduce physical activities. These things work. An intervention designed by medical students who are 20 years old does actually work because he's in a better position to communicate with a high school student. This could be the way to intervene. Just let medical students, let university students deal with their age groups. Volunteers. We have volunteers who are doing very good job on risky behaviors, diet, physical activities. One more thing that we talked about with the applying an intervention, a cost-effectiveness intervention, is the gatekeepers, the social norms. We need to accurately address these people and see how can we actually intervene in a best fit, in a best buy scenario. And I hope that will...
Thank you, Dr. Khalid.
Thank you.
Before opening the floor for the audience, I would like just to share the experience of Emirates, which has been started recently with what has been said by Dr. Muhammad Alam. The public awareness is very important. Dr. Professor Khalid, he had a big emphasis on that. Public awareness with youth, with the young generation. And there is a charity called Majid Al-Futtaim Charity. By the way, I was chaired of the board of trustees, the scientific one, to establish a program for the prevention of different type of cardiovascular diseases in the Emirates. And we came up with the model that to start with the schools, grade 4 plus, and the universities, and to have ambassadors from the schools and the universities. And those ambassadors are not the trainers, which they will go and train them. We select the students at each grade, different schools, girls and boys. Those will be trained well to avoid having junk food, to have a best exercise, best lifestyle, and to avoid different type of diseases with the proper management, that those ambassadors as students, they are the one to train their brothers, their sisters at the school with regard if it's governmental or the private schools. And this program will be continued for 54 number of the schools all over the Emirates, and then as a model for 1 year, and then the outcome will be well studied, and then probably it will be generalized through the Ministry of Education and Ministry of Higher Education for the universities at the level of Emirates to make sure that we will start with youth, with young generations, and the program will be adopted, will be managed, will be organized by the students themselves, with regard if it's at schools or at the universities. And I think the outcome of this will be a great help for the Emirates community. Now, if you will allow me, ladies and gentlemen, to start with the first school, which you do connected to the same issue. Professor Khalid, you have found that you are a member of the Pan-Arab group for the study of endocrinology and diabetes. I would like to know that what has been happened as an outcome of your meetings to support the public awareness at the Arab region, while, as you know, that we as a GCC, we have a common lifestyle problems, and the rest of the Arab countries, they have also a sort of similarity. Can you tell us what actions has been taken at this level?
Thank you. This is a very, very smart question, and I will try to answer in a political way. So let me tell you, in our part of the world, the scientific community is only responsible for having some scientific activities and updating doctors. So we belong to the 25,000 money you saw, where we have very less effect. Unfortunately, the community societies are now in our part of the world is just coming. I can tell you, I'll take Saudi Arabia as an example, and I'm sure the people in Jordan also, I'm aware of my colleagues from Jordan who has really tried to do something, that there are now different associations which are really coming up, and the government is really supporting those associations. But we are, I think we are in the earlier phase of these societies. So I think we are working in a very high costly type of societies where we are only educating the top class physicians. Unfortunately, they are supposed to go and do something when they go back to their countries, but this is not the case in general. Unless we really promote and activate the public associations. There are 3 or 4, for example, diabetic associations in Saudi Arabia. And I think they are really trying to do something. I could see that they started screening. I was even pleased to know that the Emirates Diabetic Association, 2 years ago, they launched a mobile unit that goes around and screen for diabetic patients. This is part of level 2, if you remember, on my graph. So I think we need more and more into this. But I think at the same time, I would add my voice to my colleagues. And I would like to also second your opinion about different declarations and different decisions have been done at higher political levels. Unfortunately, it didn't really yet materialized. I don't know why. Is this because the associations who are supposed to take it and execute it are not active at this moment? I cannot really answer.
Thank you, Professor Khalid. The floor is open for questions. Before taking any question, I would like to, from each single person, to present yourself, your name, your title, and from which country. We can take, always they say ladies first. We can take the first lady here. She will present herself.
Dr. Mariam Al-Jalal, I'm Assistant Under Secretary for Primary Care and Public Health. Thank you, Dr. Khalid and Dr. Thomas, for the presentation that was transferring knowledge into money. First of all, I'd like just to correct an information regarding the studies that was published about Bahrain, the prevalence of diabetes, because I see that the old ones. And I'd like to inform you that in 2007, we did the stepwise survey, and the prevalence of diabetes was 14.2, because the 0.3 The previous studies were looking at age group 30 and above, and our study looks at age 20 to 65. So this is to correct the information in both studies. My question to Dr. Khalid, why did your study include only ages 30 and above? And looking into this age group that you chosen, it will raise the prevalence of diabetes. It will show higher results, higher prevalence, I mean. Have you considered, or do you have a study that looks at age 18 or 19, like the stepwise survey? I'm sure the figures will be different. Yeah. Thank you very much.
No, our study, Mariam, was from day 0. But what we have published now is only the 30s and above. And why did we choose 30 and above? Because this is where the high prevalence is. If you want to compare your data with what is known globally, you have to come at this age. I'll give you an example. You cannot say, I would like to see the pregnancy rate among women in Saudi Arabia, and you take all women. You should take them during the childbearing age, and then your data will be accurate. The same things. The major problem is type 2 diabetes. Type 2 diabetes is peaking after 20 or 25, and this is why we have chosen 30. But we do have the data. If you want me to tell you what is the overall prevalence rate of diabetes in the whole kingdom, it is about 31. 31 means there is 16% diabetics and another 16% who are really impaired glucose tolerance. This is including the children who are and young adults who are less than 30.
Thank you, Dr. Khalid. The second question is for the gentleman there.
Dr. Khalid, it's really a very I enjoyed it actually, and I have a point which is very interesting about the genetic and epidemiology. I'm sure it is very interesting scientific finding, but how would you use it? We know that genetics is non-modifiable kind of thing. As a scientific knowledge, okay, you will use it as in your data, but can you act on it?
No. Are you speaking about gene therapy for diabetes prevention or chronic diseases? I think there is a long way to go. But let me tell you that there is something called thrifty gene. Thrifty gene. We have lived for years, 100 years in this area in a famine phase. So our genes have been already implemented with the thrifty gene telling us whenever there is food, consume energy. Now suddenly we got the food. And this is why we are responding different from a Caucasian in Boston when it comes to someone who is in Riyadh. It seems that there is this memory in our genes. Now, can we treat this? The answer, I don't think we are having something in the near future.
Thank you, Dr. Khalid. Can you forward the microphone to Dr. Tawfiq Khoja here, please? We have one here. It's okay.
Thank you so much, Dr. Amin Amiri. I think this is an excellent session. Thank you, Professor Thomas, Professor Khader Bi'an, and our discussant colleague, Dr. Wasif and Dr. Khalid. I really enjoy the presentation, but at the same time, I develop sadness inside my heart. And I don't know my responsibility, and especially the people who are dealing with the strategic direction, the GCC and policy making. I don't know how to face Almighty Allah by this presentation. It is a big responsibility, and it is a national responsibility, but it's accountability from the governments. And my question to Dr. Khader Bi'an, and also to, Professor Thomas, it seems to be that interventions should be from all aspects, from different levels of societies, from the government to the public, from the community, and so on and so forth. I have two questions. Do you think that the government role is clear in this one now in the GCC. Second, do our quality of healthcare system with this raising increment 1% every year is a good quality, and does this lead to the leadership issue? Where is our leadership? Where is our leaders in this area? Is there really a lacking of capability to do the job right, or what is the issue? Yesterday we have seen a slide, 50 years in USA, UK, Australia, Finland. They took 50 years. The cardiovascular disease was 5.6, and they took it almost, and it raised up to 8, and after 50 years it comes to 3. Now we are seeing a result in the GCC around 15.4 of diabetes. How many years we are going to spend on that? Really, it is an alarming session. So I need your input in 2 issues. The role of the governments, because this is an issue, and the second, the quality of healthcare policy in the GCC, and the role of leadership. Thank you so much.
Dr. Khalid? One to you and one to Thomas. Go ahead.
Well, I think it's natural initially to focus on the acute problems, the really complications of diabetes, and try to get those under control, and those are the ones that you immediately see. Prevention is a much harder concept to start focusing on. There's not a fancy hospital or a fancy procedure that can get people to change their lifestyle. So it's probably not the first thought, but conferences like these and facing these numbers can get people to start thinking about the future. As an economist, part of me says that the problems of diabetes, especially in the Gulf states, are in part a result of success, that now we have avoided taking the physical activity out of work. So we're not burning the calories that we used to have to spend in order to earn our daily keep. And we've also now have the opportunity to buy all the food that we would like to eat. So in some ways it's a symbol of success and economic development, but now you also have to face the sort of unintended consequences of that success. So that means starting to put a renewed emphasis on prevention and education and trying to accomplish the very difficult result of changing people's lifestyles, because we like to eat the food that we want to eat, and we don't always want to exercise. So it's going to take a lot of work.
I think, just a brief comment on your topic. I think if you come at the level, the political level, and maybe at your office level, I see you have done a lot of declarations, and you have published quite a good number of guidelines. I think the government has to start working on this. And I want to tell you that this situation is not only in the Gulf states. The UN have taken a declaration on this, and they have asked and called all states to really start fighting diabetes, because they consider diabetes as equivalent to war when it comes to the mortality. So I think the government has to put a new setup of rules and regulations. Non-profit organizations, the NGOs, has to come in now, and they have to do their part. Education, I would add my voice to my colleagues. We should sit at the level of schools and universities and do something there. And I'm sure testing the prevention programs, it does work. We are sure that it does work.
Dr. Tawfiq, can I just refer back a part of your both questions back to you as the Director General of the Executive Office for the GCC? I'm quite sure that there is two elements could be used so strongly in public awareness for the proper prevention and the prevalence could come down. Number one is the media, and number two is the Ministry of Education, because if you would like to concentrate on the youth and the young generations. What was the role of your office representing the GCC countries and using the media as the, I'm quite sure that everyone knows the program called Salamatak, in supporting fighting against diabetes at the level of GCC countries? And what was the management between your executive office with the Ministry of Education among the GCC countries in supporting the youth for prevention of diabetes?
Thank you so much, Dr. Amir. This is a really interesting discussion. Actually, we start in 2003, which was an in-depth evaluation of the strategic directions for GCC Health Minister Council. And we came out that coronary artery disease and cardiovascular disease and diabetes as a top priority issue. We came out with 11 programs, and one of them is the diabetes and cardiovascular disease. And we noticed that it is not the role only for the Minister of Health. We noticed that the Minister of Education, universities, media, culture, and so on and so forth, information and culture, and municipalities, food industry, and so on and so forth. So we had several meetings with them. It is a tough job to convince other ministries. It is not an easy job. It needs a lot of dedication, a lot of negotiation, as he said, political answering and lobbying, because on the opposite side you have the industrial pressure, the food industry, the tobacco industry, the behavior of the community, and so on and so forth. We succeed with the tobacco. Okay, we succeed a lot in tobacco now, and in increasing the taxation, putting the pictures, warning pictures, and reducing the tar, and so on and so forth. Also, we succeed in having in every country what is called a national committee for school education and something like this, school health education. So we introduce what is called healthy school environment in all GCC countries. And now also we establish what is called health promotion committees in each GCC countries. And in Bahrain, we have it is a higher committee in their organizational aspect, and so on and so forth. Also in Oman, we had a very successful program which is called Nazwar program, which is a demonstration example to show that if you do an interventional activities within the community, you can reduce the hypercholesteremia, diabetes, and so on and so forth. And as an example. But really, it is not an easy job. We had difficulties in allocating money, budget for media programs and campaign. Lastly, with as Professor Khalid mentioned, that we, through the NGOs and the private sector, we managed to support the Salamatic program, which is the, about TV, newspaper, and radio. And the whole program, it is around 74 spots in the TV will come on cardiovascular disease and diabetes and healthy lifestyle and risk factor. So actually, we did a lot, but I feel that because our job in our ministerial council is to formulate policy and strategy, I feel the role of the government should be to how to execute these strategies and direct declarations. We have a super declaration, and this is another, in 2011, we had in Riyadh that the king and the majesties, the king, the sultan, and the emir, the sheikh, they sit down and they declare a resolution that diabetes and coronary artery disease and the chronic illnesses and NCD is the top priority. And they ask all institutions should support to combat and prevent this one. But how far we are there, this is a question. I am pleased that in your country, United Arab Emirates, that last month you had the brainstorming from the ministerial brainstorming, and you bought periodic examination. And so we need actually now to look, in short, I have to summarize, we need to have an action-oriented actions, not policies anymore, not declaration anymore. I think we had enough declaration, we have enough resolutions. The time is for action, and the time is that it's multi-sectorial and intra-sectorial. Within the ministries and within the institution of health, it should work together. We have a communication with the food industry to reduce trans fat, but we could not manage to reduce the salt intake, to reduce the sugar intake. So I think this conference is an added value, and I wish the recommendation will highlight on this one.
Thank you very much.
And just I would like to say that we need your support. We need everyone's support, because the Health Minister Council alone cannot work, because its mandate is putting policy and procedures, not putting actions within the country. Thank you so much.
Thank you, Dr. Tawfiq. There was a question from that side, the lady, please. The one at the back, yes. The one at the back, yes. Sure. I will come back to you, lady. Can I just add with Dr. Just let us take the question first, because they are raising their hands. Please, go ahead.
To Professor Khalid. Thank you very much for the very informative talk. My name is Patricia. You said that diabetes is at its very crucial stage in the kingdom, and that 10% die per year. In view of this situation, what can be done? And it has to be done fast, since each life is precious. Awareness is done, no doubt, but unless and until it reaches the remotest areas, and also by frequent follow-ups with them, maybe they would respond better. And maybe we could save a few more lives from this alarming situation. Thank you very much.
Yeah. Thank you. I think I could answer very briefly. We need primary prevention to minimize the number of diabetic patients, and we need strong secondary prevention. People have to be screened for their eyes, for their kidneys, for their heart, and we have to intervene. We shouldn't wait for the patients to come with 3-vessel coronary artery disease or with acute myocardial infarction. We should do something earlier. And I want to tell you that we are estimating 20,000 diabetic patients die every year in the kingdom, which is really a very large number.
Thank you, Dr. Khalid. Can you just forward the mic to the lady in the front? Thank you very much. And then we'll come back to you, Dr. Muhammad.
Thank you very much for the lovely talk. Actually, it was very interesting and informative. My name is Dr. Matlouba Zijari. I'm from Sultanate of Oman. I'm a public health physician with interest in cardiovascular diseases. I work in the NCD department. So it's just a comment rather than a question for Dr. Khalid. You mentioned that the prevalence of diabetes in Oman stayed the same, or the trend was kind of like plateau or stable. I think because since 1990, we worked very hard in Oman. I mean, lots of programs has been done for the diabetes right from the beginning at the level of the community as well as the primary care, and in addition to the secondary care as well. In the community worked both, I mean, very, very hard, like we increase the awareness of the people, educate them, and also self-diagnosis, like layperson are aware how to diagnose themselves. And we created like diabetic campaign as well, which encourage people to walk, physical activity, weight reduction, and etc. At the primary level, we established diabetic clinic at the level of the primary care who look after the patients with diabetes, and also the diabetic food clinic, which is in the in the regional hospitals and at the secondary care and the primary care as well. Early screening program, which was introduced in the country as well for any normal individual who reached 40 and above, they just go to the primary health center and have checkup for early detection of diabetes, hypertension, and dyslipidemia. We also created a diabetic registry, which is usually monitored and maintained annually. And also, we worked at the secondary level as well. Patient who is discovered to have diabetes or pre-diabetes, they just send them for their eye checkup and the renal function checkup to the nephrologist. So I think all these, and we have also trained diabetic nurse who look after the diabetic patients at the level of the primary care as well. So I think, all these together might help to maintain the level of the diabetes, at least not, made it to
Thank you for your
rise
comments.
up, yeah.
Thank you very much. We will take just 2 questions, one in the front here, and then the comments from Dr. Muhammad. Please, could you forward the mic here in the front? We exceeded 5 minutes above the time allocated for us, but due to the importance of this session and this subject, I would like to ask the management to give us 10 minutes more and cut it from the coffee break. Please. Yes, please. No, caffeine is against your health. This is much more important,
well,
please.
Let me thank you first, Dr. Amin, for leading this important session, and then thank our eminent speakers for their excellent and most informative presentations. I believe, I have a brief comment. I believe that lifestyle interventions...
You did not introduce yourself.
Sorry. I'm Dr. Mohammed Basaleman. I'm Assistant Deputy Minister of Primary Healthcare in the Kingdom of Saudi Arabia. Actually, I believe that lifestyle interventions are the major and most important thing that we should do to control diabetes and other chronic diseases. But what we are doing is not enough. Increasing the awareness, making declarations, making different guidelines, even going to schools, which is, I believe, very important to change the culture in the future among our populations, is not enough. What we need really is to enable people to practice what we teach them. And to do so, we need to change the whole environment, and we will not be able to change the environment to be friendly and allow them to practice the different interventions that we are enforcing them to do unless we make diabetes and chronic disease interventions part of the strategies of every sector, not only the health sector. I believe that we have done a lot in the health sector in terms of health education and awareness, but what we are missing is to enable the people to do what we teach them. Thank you very much.
Thank you very much. Dr. Mohammed, in 1 minute, your comments to Dr. Tawfiq.
Yeah. I just want to reiterate what Dr. Professor Tawfiq Khoja said. I think he made a very important comment, and which is having the resolution. We have resolution. It is really good. We are fortunate that all the leaders in the Gulf countries agree upon, and I think this is a great reward for Dr. Professor Tawfiq Khoja to bring it all the leaders in the health to make them understand that how important diabetes is. So it's a big achievement, and it's also a big achievement that the United Nations recognized diabetes as a world problem and included diabetic amongst all the other chronic diseases like cardiovascular disease, cancers, and respiratory problems. So these are all achievements. I think we need to celebrate those achievements, and now we need to really work how to really use those recommendations and guidelines. I think it's a very important thing we need. Let us celebrate that and let us move forward.
Thank you, Dr. Mohammed. Dr. Maydur? No, the lady behind. Could you forward the mic there, please? Yeah. Maydur. Wadad al-Maydur. Then they both take one question.
Thank you, Dr. Rabi'an and Dr. Thomas, for these.
Go ahead, please, go ahead.
Thank you, Dr. Rabi'an and Dr. Thomas, for this great informative presentation. I'm Dr. Fatma Al-Slail, Public Health Specialist and Director of the Diabetic Prevention Program in Saudi Arabia at the Ministry of Health. I think we came to the point that we are in need right now to adopt and implement the diabetes prevention program. There is no doubt about it. We have seen it on the presentation. But I think one issue we're missing, that we need to have a cooperation from everyone, and most of the social media, and the other part, the developers of the video games. Yesterday we have blaming the video games a lot, okay? Why don't we have them on our side, not like in enemies? So we have to have like the adaptation of the guidelines. Yesterday we have seen it. It's a great tool. You have the guidelines in your mobile phone, but it's for the people who's like, let's say 40 and less than 40, they're not going to have this application. We need to change this kind of application to have it more attractive for these people. Even the social media, children now 7 years, even less, we have seen them having their mobile phone in their hand and going to the Instagram or whatever, uploading their unhealthy food. They are promoting this. Why don't we use this social media to advocate what we are saying, like a campaign on healthy food? Okay, and we have the incentive for it. Let's say the person who's uploading multiple pictures with a great food will have a prize or something. It's an incentive for them. So, thank you.
Thank you. Excellent. Dr. Wedad, please.
Yes. Consultant family physician. I'm head of the tobacco control program in UAE. I have very short 2 comments. First of all, I wish in the second Arabian Gulf public health research that we will see a best practice. Research more and more about the best practice that is going all over the world. We are not living alone in this world. I think many countries who had lots of effort to put these behavioral science in place and help us how to help our community to change and go from knowledge to so on, and then success for behavioral changes. The second comment, the council, the GCC Council Office, they are having a great effort in supporting the people in the medical field to put things in the place with the strategies, with committees all over the GCC. And I think we need more and more support from the people who was supposed to helping us to put these declarations and strategy and so on in a place in each country. Thank you.
Thank you, Dr. Wedad. I have a last, ladies and gentlemen, you have two options. Either you will give up with coffee break, we will continue until 12:30, or we will close now and we will go for the coffee break. Huh? 40, thank you. The last question, I have a small question for Dr. Thomas. You know, recently there is, some of the health authorities are approaching us as a ministry. You know, we have a Emirates Medical Council responsible for putting the laws, regulation for health in the level of the country. Through one of the insurance companies that they would like to minimize the cost or the cost burden on the governments, and they would like to have a sort of a distance result consultation between the diabetic patient with his physician, and instead of the patient to visit the clinic 12 times a year, that to have 1 visit per year and to have a prescription for their medication per month, to have a refill prescription. The prescription will be prescribed for 3 months, but it will be issued for 1 month, and they have a refill for 3 months. This plus having a consultation that the patient will check her or his glucose level at home, and then give the consultation, take the consultation by phone with the physician, and the visits, instead of 12 times per year, will be minimized to 4. You will minimize the cost on the patient, insurance companies, and the government. What do you think the best practice in this issue worldwide?
I think that's where the technology is, and we can use the technology to sort of more effectively use the physician visits for when there's a real problem. If you are checking your levels every day, there should be lots of information for the physician that can be monitored even automatically, and warnings can go out if there are problems. So I think that is a real opportunity, and the technology is there and is going to be more popular as it goes on.
Thank you very much. Ladies and gentlemen, allow me to thank all the speakers and the panelists here at this session. It was very informative, and we thank you as an audience we thank the Emirates Strategic Research for all this conference. Thank you.
Bismillah ar-Rahman ar-Rahim. In the name of Allah, most gracious, most merciful. I am very pleased to be here with you, all of you, and it is an honor for me to be in this respected center. And really, words cannot express my gratitude to all of you here in the center. Sheikh Nahyan, Dr. Jamal, and Dr. Wayan for such excellent organization of such conference, and at the same time, a very respected colleague I have seen since yesterday, and he raised a lot of very topical issues in the GCC countries. So together we are working in the way forward to improve the health of our beloved countries, citizens, and people who are with us here in these countries. And I wish with your, after the Almighty Allah help, with your commitment, we can achieve our target and objectives and aims. Today we have four respected colleagues, Dr. Matthew, Dr. Widad, Dr. Muhammad, and Dr. Jamila. I really advise you to see their CVs, but I will try to highlight in short who are they. Dr. Matthew, he's a Chief Scientist and Senior Director of Public Health Policy Research Program, RTI International USA. He has a lot of studies and so many work regarding tobacco control and research and education. He's a figure in this area, and he really did a lot of work to improve the policies and programs in tobacco control. Also, in area of cigarette and tax, how to increase the tax for tobacco and cigarettes, and what is the role of mass media, and so on and so forth, in order to control tobacco consumption in USA and other parts of the world. Dr. Widad Al-Madyur, she is a family physician consultant in Dubai Primary Healthcare, MOH, and she was graduated in 1993, and she worked in different healthcare institution sectors, and also she was shifted from the medical hospital to the primary healthcare field in Dubai in 1997, and she was awarded from Sheikh Rashid Award in 2001, and she was appointed as a director of primary health care and the head of tobacco control department at the Ministry of Health and the national focal point for tobacco control in UAE since 2007. My brother, Dr. Muhammad Al-Yamani, he is a professor of pharmacology, clinical pharmacology and hospital pharmacy. He started his career as a pharmacist in King Khalid University Hospital, and he was an active member of 4 main team to establish the pharmacy services at King Khalid University Hospital. He has a lot of studies and work in improvement of clinical pharmacy and area of endocrinology and area of tobacco control. He is also a consultant for or advisor for the Minister of Education, Higher Education, and the Saudi FDA for Food and Drug Agency. Also, he's the chairperson of the Saudi Society of Tobacco Control or Anti-Smoking Charitable Organization, which is named as NACA. He has a lot of initiatives to control and prevention of tobacco consumption in the Kingdom of Saudi Arabia. Dr. Jamila Al-Khanji, she is currently work as an advisor of research and studies, Family Development Foundation, Abu Dhabi. She was as an advisor and as the director of the Community Services Division and acting managers of the Strategic Department and manager of the Health Department. Dr. Akhanji has conducted many seminars and training workshops and published numerous papers in the field of specialization and include brain and healthy lifestyle and learning strategies in Europe, in Europe and the United States. And she was considered as a pioneer in the Arab world in this area. She represents United Arab Emirates in international events in area of her specialization, and she was a media spokesperson for the Family Development Foundation from 2008 to 2011. So with this, our colleagues would like to open the MISC session, the last session of the whole excellent program about effective mass media campaigns in public health. And as you see that we are going to speak about issue of tobacco. So before I give the floor for my excellent colleague, Dr. Matthew, I would like just to quick in 3 minutes or less to highlight why it is very important to highlight on the tobacco in the GCC as a particular form and the effect of mass media. The situation is a very serious situation for tobacco in the GCC. Okay, as I said yesterday, we have been seeing in the last 10 years that the GCC countries are targeted by the tobacco industry as an alternative solution for their reduced consumption in America and European countries. And there is increased consumption of tobacco in the GCC countries, and this is reflected in the raising budget of money spent on tobacco. The GCC Health Minister Council since 1979 has so many declarations and resolutions in this area. Some of it has approved in the field, and it become an action, and but really others is still in the process to have an effect. Imagine that every third person in the GCC age above 20 he's smoking or he's smoking, and with the figures shown by Professor Khader Bi'an, diabetes every third or every fourth or fifth, hypertension every fourth, and obesity every third. And the studies conducted by the WHO showed that unless effective community awareness, so the mass media here is very important, setting national policies and commitment are taken, the prevalence of smoking will increase 0.5 to 1% each year. So, as Professor Khalid said, every year we are going to have increment of diabetes, so increment of smoking. And imagine that the mean age of starting smoking in the GCC is 13.8. So this is the mean age. And between the age of 15 to 19, almost 20% of this age group, they are smoking. They are smoking. And the starting age of smoking in 3 countries, taking 3 countries, Qatar, the starting age is 15 years old, Bahrain is 12 years old, and Saudi Arabia is 11 years old. And the lowest is Yemen, is 6 years old. So this is a serious issue in the GCC, and action need to be taken very seriously. And we had a lot of anti-smoking day in GCC, and last year it was Stop Tobacco Industry Interference, and the role of media is increasing so much. Actually, what happened 3 days ago, I received an SMS from one of my colleagues. He is a family physician in National Guard of Saudi Arabia. He said, Tawfiq, open the satellite and see the Kuwaiti TV and see how the person who is smoking. The way the person who smoke, I have the picture, is really, if you see it, if you are not a smoker, you will smoke. No way. It is a very attractive, very catchy picture. And then I send this picture, and send this SMS through the WhatsApp to my executive board colleagues. And Dr. Mariam, she answered this one. She's behind the second row. And she said, we need to do a lot of work. So I wrote to the General Secretary of the GCC that we need to have a serious action on how to indulge the media within our campaign against smoking and tobacco. So this is the situation. It is not far away from diabetes. It is worse than diabetes. So here, I think from the presentation of my colleague, the four of colleagues here, we can put the way forward in the right direction. So please, the floor for you, Dr. Matthew. You have
25 minutes.
Okay, excellent.
Well, thank you for that great introduction. And this is my first trip to the region, and I really thank the Emirates Center for inviting me and the great hospitality, which has been unmatched. I really feel spoiled, and this morning's session was very, very exciting, and I think it really does stress the importance of public health. And the connections between tobacco and obesity I think are apparent, but I'll try to highlight some of them. We all recognize the significant toll that tobacco takes on our society in terms of health and economics. And just as with obesity, it takes multiple strategies to reduce tobacco use. I'll be talking about one strategy, using mass media, but many other techniques have been shown to be very helpful. Smoke-free air laws, limiting opportunities for people to smoke in public places, increasing the price of tobacco through excise taxes, but also providing support for cessation for those who want to quit. Because if you have a media campaign, it's more than just about raising awareness. It's about affecting behavior change. But if you want people to change behavior, you have to give them opportunities. So in the case of smoking, you have to give them opportunities for cessation programs. The analogous thing that we talked about with obesity, if you're going to have an awareness campaign, a campaign to try to eventually change behavior, you have to have the support in the community for exercise and other opportunities for healthy eating. For example, you need to have plentiful fruits and vegetables. Oops. So I do want to recognize there is a lot of exciting things going on in tobacco control in the Gulf countries. And I do hope that I will get to learn more and discuss all of these issues with many of you and learn from you. What I hope is that I can talk about mass media campaigns in a way that will be helpful to you all. Let's see. Because one of the things that my colleague Tim Gable mentioned is that it's important to celebrate the successes. And I think that in tobacco control, that's one thing I think those of you who are working against, fighting against obesity and diabetes can look forward to is the success that we've had in tobacco control around the world by implementing mass media campaigns and other policies. And there's a strong evidence base now for tobacco control that shows that mass media campaigns can be effective in reducing tobacco use. And there's no reason why those same lessons can't be applied to promoting physical activity and increasing healthy eating. But at the same time, I called this presentation the science behind developing effective mass media campaigns. Because although, and my other colleague, Dr. Tom Herger, mentioned, with the obesity and diabetes problem, it does feel gratifying to build new hospitals and to have lots of procedures that have an immediate effect on the health of people. But I think when we combat a public health problem as big as obesity, as big as tobacco, it's really about affecting a large population, educating the entire population, and to be patient. Because we can't expect that immediately people will drop their cigarettes as soon as they see one of your brilliant ads. It takes time and patience So you have to be dedicated to stick with this fight. So some of the questions that you need to answer when thinking about implementing a mass media campaign is what level of campaign, what level of awareness do you need to reach, and how long do you have to sustain this campaign to be effective? And then also, what should be in the ad? What is the creative strategy that will make people pay attention and really think about changing their behavior? And who is that target audience? Who do you think is susceptible to changing their behavior? You have to think about who they are and think about how to reach them, how frequently to reach them, and with what messages. And then also, our media environment now is very complex. There was a comment about social media. Mass media comes in multiple forms: television, radio, internet, through social media, through viral ways of diffusing information. There's a lot of choices. So to leverage the power of the media, you have to really think carefully of how best to do that. So the purpose of this talk is to review the critical issues to attend to if you want to have a successful campaign. I'll summarize the evidence base that exists, as well as talk about some specific examples from the US. I think that while those examples are examples of success, we have to think critically of how those campaigns might be adapted to the GCC. And again, you can be thinking about how this might apply to the problem of obesity. So early on, before we really knew what we were talking about and doing in tobacco control, there was a nice review, a publication by Bob Hornick from the University of Pennsylvania that summarized that many campaigns failed, not because they're creative, their messages weren't good. In fact, many of them were very good, but no one saw them. Not enough people saw them. And I like to talk about this in tobacco control. It's really about simple math. You need to reach a significant proportion of the population frequently enough and for long enough to affect population change. What's that magic level? I'm not really sure, but I've always tried to say that it's at least 60% of the population. Because if you're only reaching 10 or 20%, you can be really effective. You can have brilliant messages. But think how slowly the population level will change if you're reaching such a small proportion of the population. And US CDC best practices recommends that you reach 75 to 85% of your target population to have a behavior change. And then also you have to be patient. From the day that you start, don't expect in 6 months that you'll have significant population level change. Will you see some change right away? Yes. But will the whole population move in a way that can change prevalence? It won't happen overnight. So that's something that you have to talk to the decision makers, those who are funding the campaigns, that they have to be patient. And that's a hard lesson. When you talk about political support and gaining political support, they have to be prepared that this is not a problem that's solved overnight. We just celebrated the 50th anniversary of the Surgeon General report in the United States. And yes, the smoking rate's been cut in half. We do have success, but it was a 50-year fight and it's still not over. So patience is something that they say is a virtue. But the encouraging thing is that there is really strong evidence around the world that supports that mass media campaigns can reduce the smoking prevalence, initiation, and progression to greater use. So how do they do it? Well, common themes are some of the things you might think about. Highlighting the health consequences of using tobacco. But also, there have been cases in the United States and elsewhere of shining a bright light on the tobacco industry's manipulative advertising and way of seducing people into smoking. And so countering their very effective advertisement with counter-advertisements is a strategy that's been used in the United States and elsewhere. Another thing is to think about exposure to secondhand smoke. Parents who smoke, they have children oftentimes and they're worried about the exposure of their children. That's a message that you can use, highlighting the dangers not only to themselves and their friends, but their children. And then also just trying to change the social norms, reminding people that not everyone smokes, and in fact, most people don't smoke in many countries. So one of the things that sometimes is a hard lesson to learn in terms of the strategies for campaigns is that the very friendly, positive, upbeat messages, well, frankly, they don't always work. And in fact, they probably don't work very well compared to some of the other stronger messages that highlight fear or disgust. And because those are the ads that those that are most at risk say that they like the most. So it's okay to use humor on occasion, but if you really want to get inside people's heads and change their behavior and change their way of looking at tobacco, you may have to use stronger messages that some view shocking. And I'll give some examples. But the good thing about those messages is that people get complacent. They smoke every day, they know the risks, but it's easy for them to ignore. So the campaigns that have been effective really are getting in your face. They're really reminding you that if you keep using tobacco, there are serious health consequences. So the other complicated thing about implementing an effective mass media campaign is that there are lots of different variables that go into a campaign. There's the message, there's the actors, the tone, is it positive, is it negative? What other kinds of stylistic features do you need to think about? And sometimes it's hard to really separate out which was it. Was it the message? Was it the frequency? Was it the fact that we reached a significant proportion of the population? So one example from the United States was what's called the Truth Campaign. It started in 2000. And by about 2002, 2003, it was shown to be effective at reducing youth smoking prevalence and initiation. And the style that they used was to go right against the tobacco company's imagery. If you wanted to be a smoker, and especially in the early days, they used images of a cowboy. Because what do you think of when you think of a cowboy? Well, when you're in the US, you think he's rough, he's rugged. And he's someone that many people will look up to, many men will look up to. I want to be tough, I want to be like that guy. So then the Truth Campaign said, well, you might be that body bag. You might end up being that body bag draped over that horse. So really using their own images right back at them. And this was very popular among the youth. The campaign was successful in reaching 75% of the teenage population. The kids that were most at risk for using tobacco said that they really liked these ads. And they were exposed to these ads frequently for 2 years straight, every day, over and over and over again. And that's what it took. But it was successful. The prevalence of smoking declined significantly. The one thing that I will say, that with youth, we know that it's important to reach a high proportion of the youth population. We don't really know exactly what strategies. This was an effective strategy. Will this strategy work everywhere? Probably not. This was a long time ago. Today's youth may think something else is attractive. So the second half of my talk, I'll help you figure out how might you figure out what types of strategies would be most successful. When you turn to cessation campaigns, so aimed at adults to try to get them to quit, I think that there's a lot more convergence in the literature about what's successful. At least this has been true in for English-speaking audiences. And one way that many of us in the literature talk about the different styles of messages are two different types: how to quit and why to quit. So the how to quit is really about messages of giving people solutions of how they can go about quitting. If they've already come to the place where they realize, I want to quit and I'm ready, you need to give them solutions for that. And so oftentimes in the United States, they highlight toll-free cessation hotlines where people can call and immediately get help to quit, as well as nicotine replacement therapy for free. But one thing that's really important, and I even have to remind my colleagues in the United States often, is that only about 2% of smokers will call a quit line in any year, 2%. So what about the other 98%? You have to give them messages that is going to provoke them to take some other action. Quit on their own, which is still the most common strategy of quitting. It's called quitting cold turkey. You just decide one day you're going to quit. And many people do. But how do you get them to that place? Well, that's where the why to quit messages come in. You need to give them reasons to quit. Now, almost all smokers realize that what they're doing isn't good for them. They know the risks. But I think sometimes they think about it, yes, in general, it's a problem. But maybe they think about their uncle who smoked 2 packs of cigarettes every day and ate a pound of bacon every morning and lived till he was 90. And they think, well, maybe that'll be me. Well, So all of these ways that smokers will rationalize continuing their habit, you have to somehow penetrate that thinking. And how do you do that? Well, the ways that have been successful is taking real people, real smokers, who have had an impact on their lives as your spokespeople. This strategy is called the personal testimonial style. And oftentimes, they're sad messages. They're messages of the person talking about how it's impacted themselves and how it's impacted the lives of their family. And so, again, they're not the happy, positive messages of, oh, if you quit, life will be wonderful. This is, no, if you keep smoking, this is the damage that you will face. And another strategy that's been used quite often is graphic images. Very disturbing images of body parts, diseased lungs, arteries that are clogged. Again, to really shock people. Now, these types of strategies are called a fear appeal. And the one thing that's really important to focus on when it comes to these types of messages is that the health communication literature says if you scare people with fear, you have to be very careful, because if you don't give them a solution of what to do with that fear, they will reject you and they will reject your message because they're trying to control the fear. If they don't know what to do about their habit and they see a message that's disturbing to them, they're just going to ignore it and ignore you. But if you couple that message of fear with a solution, call this toll-free number for immediate help, or other campaign messages that let them know there are effective strategies to quit. Nicotine replacement therapy, counseling, call the quit line. As long as they know that's there, you've opened up a little window for dialogue. So then maybe they're still fearful, but they know that they can start doing something about it. And so they start to think about, okay, what are my next steps? And that's the kind of thing that has been successful. But you don't want the fear messages alone. And that's why it's just another reason why tobacco control, just like obesity, you have to think about this as a multi-strategy solution. So here's an example, a very recent example. The US Centers for Disease Control used this strategy. They looked at the literature, and they realized this personal testimonial style, showing the health effects of smoking, is very effective. It sends a message to people. These messages are authentic. So the campaign initially launched in March of 2012, and it's still going on. But even after the first 3 months, there was a discrete impact of the campaign. I'm not contradicting myself. From before, these are people who called the quit line, so there was some evidence that there was an immediate impact, and there was an increase in quit attempts. But the thing about tobacco is you have to stick with it. Many people quit every year, and they fail. So that's the thing with smoking, is that many people quit, maybe they last for 2 weeks, a month, and then they go back. So it's still uncertain whether this campaign will have a lasting impact on the quit rate. But this is Terry Hall. This is a real person. And she had a stoma from smoking. And she's shown here at age 52. She says, record the voice for your loved ones while you still can. And unfortunately, last fall, Terry Hall died. And before she died, she recorded one last message for the campaign, which will be airing soon. And then briefly, just another thing, there's another strategy that some have used to try to prompt healthcare physicians to talk to their patients more about smoking, because that physician advice can be very powerful. So New York State used this strategy, and we evaluated it at RTI. And while there were some limitations to our evaluation, there was some evidence that this prompted doctors to talk more about smoking with their patients. And the sutures you see on the mouth was, again, using that strategy of graphic images to try to really get the attention of doctors. So they think, well, that's not me. I'm going to talk to the doctor, to talk to my patients. So now I want to transition to the other part of my talk, and this may be a bit of an eye chart for you, so I apologize. But this is just to give you a sense that there are many steps in developing an effective media campaign. So one step, so after you've figured out who you want to target and what kind of strategy in terms of what segment of the population, there's formative research and concept testing that I'd like to talk about. Because again, you can't just throw up any message and hope to be successful. So for example, I said that these graphic images and emotional ads are mostly effective. But I think for your culture, for your country, maybe you want to test those ads and see if they resonate with the population. But it's possible that other strategies will be necessary. So to do that, a carefully done campaign will start with qualitative studies, such as focus groups. You're trying to talk to the people whose behavior you want to change, to find out what will likely be salient messages for them. Leverage points, something that you can highlight that will get them thinking about and ultimately changing their behavior. So we start with qualitative data, but eventually we move to quantitative data so that we can test the messages and get a better sense of whether the campaign is likely to work. And I don't know if you can see all of this, but this just underlines that this is a multi-step process. This is based in the theories of health behavior change. And what's important is to measure the exposure to the campaign among the population, but also to measure what we call receptivity. The easy way to think about it is, do people like your ads? Do they find them compelling? And then the next step in that process, is it shifting their attitudes? And the key to a successful campaign is to come up with those beliefs about tobacco that are closely tied to the behavior that you want to change. And then working backwards, you think of messages that you can use to start changing those attitudes. So the purpose of formative research, you're talking to the consumers, you're talking to your audience to understand the factors that influence their beliefs about the behavior. Find those leverage points, and then tailor your messages to those points and test them to see if your message is getting through. And then after that, if you're talking to youth, think about, can you use social media? Can you use the internet to deliver your messages? Or is TV the best strategy? So what mix of messages and through what channels will you be most effective? And Tawfiq, can you give me the 5-minute warning? So what do we want to learn from the formative research? So much of the evidence for campaigns comes from the US, Australia, and Europe. And while I think there are many really good lessons from this literature, I think it is important for each culture to understand what messages and strategies will be most salient. I think just taking messages and translating them from English to Arabic may not be the best strategy. By getting people that are in your target audience involved in the process, you can get key insights that may make your campaign more effective than those in the past. So if you think about this formative research in 3 stages, first you do an exploratory phase. Then you move to testing out different concepts to see which ones stick. And then once you finalize your ads, you want to do some pre-testing before you spend possibly millions of dollars doing lots of advertising. You want those ads to be as effective as possible. So where I think our group has made a lot of contributions to the literature is coming up with quantitative measures and metrics that will tell you whether or not you'll be successful with your campaign. These are metrics that are grounded in theory and honed through practice. We've used them for many campaigns. That CDC Tips campaign, they used our measures to pre-test the ads before they went on the air. FDA is about to launch a media campaign for youth prevention. They gave our metrics to the advertising agency to test their messages before going in market. And then, of course, it's important once you're in market is to test the messages and to make sure that they're performing the way that you expect. So when we started this work in the late 1990s, most of the assessment was asking people, do you like the ad? Did it make you think about or talk about the ad? And while those are helpful, they don't get at some of the important things. So we expanded those measures through a series of studies. And what we found was that this measure of perceived effectiveness was not only helpful to compare one ad to the next, but we demonstrated that the higher the receptivity, the more likely you were to see behavior change. So we were able to validate these messages. So those that give higher appraisal of ads are more likely to change their attitudes and ultimately change their behavior. So what are these measures? So what we started to ask was, ask each person about each ad. Is this ad powerful, informative, and or convincing. But also we get at the emotion, so that's more of a cognitive thinking process. But then we also get at the emotions. Did that ad make you feel hopeful, motivated, afraid, ashamed? And the way that we've done this most is through web-based surveys where you can actually play the ads so that people can see them, and then you ask them about each ad. We also used this technique to test 36 different graphic health warning labels for the FDA to winnow it down from 36 to 9. So just to wrap up, mass media campaigns have been shown to be effective in reducing tobacco use in the United States and elsewhere in the world. But it's not necessarily a simple process. I want to really highlight that if you want to change behavior, whether it's physical activity, healthy eating, tobacco, you're in it for the long haul. Expect to spend a lot of money. Convincing the media on World No Tobacco Day to talk about tobacco for a day might make you feel good, but it should only make you feel good for about a day. The other 364 days of the year, you better be thinking about how am I going to reach my audience every day, or at least several times a week, if you want to have a successful campaign. And it takes money. And you have to think about how to reach them in multiple channels. And again, you have to be careful and think through what messages will be most effective. But luckily, whether it's for tobacco or you're thinking about promoting physical activity, there's now a strong evidence base upon which you can build your strategies and use these various metrics to guide that campaign so that your investments pay off. I really look forward to talking to all of you more about this and the panel. I feel lucky to have such a distinguished panel to talk about these and hear your successes, because in fact, we in the United States, we've been successful with media campaigns, but do we have graphic health warning labels on our packages yet? No, but you do. And you have some forward-looking policies that we have not yet been able to implement. So hopefully we can bring you some helpful information, but I think there's a lot for us to learn from you as well, and I look forward to the conversation.
Thank you so much, really, Dr. Matthew. This is an excellent talk, and really, as I discussed with Dr. Widad, it opened a lot of doors and thoughts in our GCC programs of tobacco control and prevention. Really, it is an interesting approach towards such an epidemic of consumption of risk behavior, which is tobacco. Now we are moving to our second presentation to a person who she's a colleague of mine, and she's really a very active person in tobacco cessation and control in the GCC. She worked very hard to bring the warning pictures with her colleague, the other members in the GCC committee. Also, last year we had a very excellent conference about tobacco, and from that conference we update our strategy directions for GCC countries. So, Dr. Widad Maidour, please, the floor for you. Mass media campaigns for tobacco cessation in the United Arab Emirates. The floor for you. Thank you.
Bismillah ar-Rahman ar-Rahim. Thank you very much, Mr. Chairman. And I extend my thanks for the center also, the EC Center, for giving me the chance to talk about tobacco and cessation in UAE. And this presentation will try to be as much as to the time. We'll talk a little bit about tobacco endemic, then tobacco use in UAE, the situation, what is our summary of our plan, the tobacco dependency therapy activities in UAE, how is it going on, and how did we use the mass media for marketing and encouraging tobacco cessation in UAE. Of course, when we talk about tobacco, it is the biggest enemy It is the worst leader, the world leader killer. Tobacco kills more than the other highly infectious disease in the 20th century. And tobacco is killing 6 million people per year. And 100 million will be, died in 20th century. Every 8 seconds, one person died due to tobacco use. And if current persists, if the effort will not be strong and continuous and mandated, monitored, tobacco will kill 8 million. Death in the 21st century expected to be 1 billion. Of course, people who smoke are having death rate 3 times higher than non-smoker. And also the great challenge that is faced for the health systems, which is the non-communicable disease. Tobacco is the cause of death in 68% of the non-communicable disease death. Unfortunately, the epidemic is shifting. When we look to the figure, we will see that it is now the investment in tobacco is moving to this area, and especially in the GCC country. So we have to have lots of regulation and offers to protect our nations. When we talk about tobacco use in the country, cigarette, of course, is the main three types used in the country, which is the cigarette, leading the market with 6.24 billion sticks. Shisha, with around more than 1,000 cafes all over the country. Midwah, it is something attacking the nation, especially among the young, and increasing and spreading lots, and we need to study more this type of tobacco use. There is no size of the market. Now, electronic cigarette and chewed tobacco are banned in UAE. Regarding tobacco use in UAE, from our short and simple studies that we did, 25% is the adult tobacco use in UAE, according to the National Health Survey in 2010. In Dubai itself, it was 18%. From Waqaya Insurance survey for screening study, it showed that it is 24% among men and 0.8% among female. So among adult, it is a high percent. And when we go to the teenager and the young between 13 to 15 years old, we repeated the Global Youth Tobacco Survey in UAE 3 times in 2002, 2005, and recently in 2013. We didn't announce 2013 yet because we got the fact sheet and we are doing processing with the data analysis. Ever smoked, it seems that teenagers thinking, trying to smoke, the percentage is high. But current smoker to any type of tobacco in 2013, it is 16 in comparison to the last 2 survey. This means that, thanks God, our effort is working. So we have to continue to be hard worker. And also, cigarette smoking, it is decreasing, and never smoked, it's also increasing. So with this simple data, I think this has given us more push to work harder for our nation. When we talk about tobacco control in UAE, we summarize it in one vision, 5 strategies and 6 actions. Our big goals, our visions that we will toward society free of tobacco use, of course, and free of complications. The main goals, of course, to eliminate the tobacco and through primary preventions, trying to reduce the burden of tobacco morbidity and mortality caused by tobacco. The 5 strategic aims: primary prevention, not to start tobacco use, ensuring 100% smoke-free public places, establishing and promoting services for cessation of tobacco, active surveillance system, and the monitoring of tobacco use, because definitely it's very helpful for planning and requesting more and more from the nation to support us issues and reinforce the legislation in tobacco control. The sixth action, of course, we are trying to put the beautiful six empowers strategy of the WHO in action in UAE. And when we talk about tobacco cessation, we talk about maybe O and W, where we talk about we have to be active in offering helps for people. We have to put effective warning and disclose the tobacco product, let the customer know exactly what they are using. Of course, M for monitoring, B for protecting people, and we are working hard to reinforce our laws for ensuring 100% smoke-free and effective advertising, banning any type of advertising, and working hardly to raise the price of the tobacco, because in the GCC, the tobacco is very cheap. When we talk about our effort in tobacco dependency in UAE, of course, the effort is going back to the even 95, but since 2007, was more and more collectively through the country, and everybody was active. So smoking cessation is growing surface all over the country. We have a toll-free quit line. Some of this line will give the support and assessment to quit, and some of this line will help the smoker to reach to the proper clinic and give appointment and so on. Regarding MOH, we have already so far 9 clinics, 3 of them in the school. And the Dubai Health Authority also, the service is available in the primary health care. In ADNOC, which is the petrol company, also they are very active in supporting, making the workplaces healthier. And universities, like in the American University and the high technology and the Sharjah University and etc. When we talk about tobacco cessation in the UAE, we started with 2 clinics and now we go up to 12. Our very simple data showing us that is with this very great effort that we are doing, small support that we are getting, there is a good registry, there is a good number of smokers who is really thinking and trying to quit smoke, and it is maintained. This is the smoking cessation numbers who came to our clinic and who quit in the MOH data in 2010. When we talk about tobacco cessation policy, of course, there is lots of interventions, as Dr. Thomas said, strengthening motivation to quit, trying to reduce the obstacles and difficulty to quitting, creating non-smoking norms, reducing stimuli to start to smoke, but also smoker want help and encouragement to quit smoking. So behaviorally based, as Dr. Thomas also helped us to understand more and more this process, that intervention are cost effective. Behavioral intervention are most cost effective than service delivery. And tobacco use is very risky behavior, so we have to learn how to help our nation to, what is the effort that we should do to reduce the tobacco use. Mass media campaign is an element of broader health promotion. And when we go through the mass media campaigns, the effective one will be that we will help the nation to have a very good knowledge, so we will go to raise awareness and then try to change the attitude, reaching to changing behavior. Mass media campaign, also the tobacco company trying to, when we put, for example, 1 million, they will put 1 billion to market for themselves, to compete with our efforts. In the United States, it is 8.8 billion annually for marketing and advertising. Of course, in our country, direct advertising, it is banned since long time, even before we have that ratified in the FCTC and so on. And also the TV and radio, it is also banned since long time. So thanks, we were, with our efforts since 2007, we will be able to ban any type of direct marketing and sponsorship and all this. What we have to work in the indirect marketing, which is showing the scenes of the, like such pictures in the cartoons, and also in the continuous series that is showing in our TV or cinema, which is the indirect. This is what encouraged, like Professor Khoja stated just a few minutes, that it encourages you to smoke even if you don't want to smoke. So tobacco marketing will cause the kids to start to smoke and maintains tobacco dependency. So what we should do to ensure that the mass media that we will use is effective to raise the awareness and also start to change the behavior. So we went for informing and educating the public, bringing public partnership, voluntary, the privates and the professional sector, good mass media coverage, try to reach as much as we can, working with leaderships for a better advocacy, encourage local and national policies to create supportive environment and social norm. So when we start about informing and educating public, of course, we have to tell the people how dangerous is tobacco and disclose the tobacco content. But at the same time, we have to support them because they know the dangerous, but they need our support. So in 2007, we started with this slogan that كل التدخين ضار فلتكن صاحب قرار. This means that all types of tobacco is dangerous, so you have to be a decision maker and take your choice. And in 2013, we launched a national campaign. It is especially toward the youth and young, and tell them that you are too smart not to start this type of habits. And this is an example of the ads usually that we see from other partners in the country, healthcare giver like HAD, that we try to use also choose the suitable or time, like during Ramadan, people are fasting, they are not smoking the whole day, so we encourage them to quit smoking during that time. Bringing public partnership voluntary, of course, for example, the Red Crescent in UAE is very helpful since long time trying to support us in establishing a smoking cessation clinic in the schools. Private pharmacies, we have alliance with them to encourage, to educate their pharmacists so they will start to talk to the smoker. Government workplaces, they are inviting us all over the year to support their, especially their workers. When they will see lots of smokers, they will invite us to be part of them and to encourage healthy working environment. Emirates Medical Association, they are very great support for us, and lots of universities trying to help us either to bring the service to the university or putting the tobacco control as part of their curriculum and part of their project for their student for graduations. Of course, this is like a type of marketing for tobacco cessation, and the one with the cigarette, it is from the police. Police offices, they are encouraging their people and their employee to quit smoking. When we talk about good mass media coverage, we try to use the modalities that can reach to much of the people. In 2007, when we started the campaign, we used the radio because in the country, lots of people listening to the radio while they are going to the work or while coming back. So really, this helped us to get lots of people to the clinics. Also, the TV ads, and we use a national song, which we are marketing for it, that is say, cross the heart, I will not smoke because I love UAE. So we try to link to the national, to link it to the emotional, and so on. And also we have the website for our national campaign, Adka UAE. Now, also we work with our leadership. They are very supportive. We work with His Highness Sheikh Maid bin Mohammed bin Rashid. He is the leader for the two campaigns. One campaign from the Ministry of Health and the other campaign from the Dubai Health Authority, Tobacco-Free Dubai. He's supporting this campaign, and also he is supporting our campaign. So we try to choose young, non-smoker, healthy, active, encourage our teenager and young that I am a model, I'm not smoking, I choose the good, I choose the sport and stuff that, and so on. Also, we encourage local and national policies. And recently, yesterday was for us the great day in the country, that 21st of January is the reinforcement of the bylaw that we were waiting for 4 years almost. So hopefully with the collaboration of all over the nation, all over the country, that we will be able to reinforce our law properly. Now, what is our future plan? We are trying to reach to the young, because their favorite is cinema. We try to reach through the social media because it's cost effective. linking the campaigns to the policy. We're going to have, soon we will have a campaign with the bylaw, also educating the people that by law, you are protected from smoke, so you choose for yourself. Integrating the tobacco treatment within the primary health care, and also working with our community members for more and more and better advocating. Research, yes, we need a research in this place. We need to know, as Dr. Thomas said, we have to understand which is the best message. Are we delivering the good message? Are we reaching to the proper place, to the proper country, proper groups? Is it acceptable by the youth? Maybe it's not acceptable by the old age. So we have to test our message to have a good mass media result and effort. Taking home message, of course, cessation doesn't work alone. Cessation doesn't work without training. Cessation will not work without commitment, and also it will not work with medication alone, and does not apply for everyone. Thank you very much for your listening.
Thank you so much, Dr. Wadad. This is an excellent work conducted in United Arab Emirates, and it shows the accountability towards this very important issue, which is tobacco consumption in the United Arab Emirates and also in the GCC. Actually, we learn a lot from Emirates and the rest of the GCC, especially in open places and laws in the airport and so on and so forth. But we still need more activities in the duty-free and others area. By the way, in Abu Ali Mountain, there was a factory there as was targeted for youth, and in 2001, am I right, Dr. Fikri? 2001, there was a resolution from the GCC to ban this factory and to stop the advertisement for youth for tobacco. And in 2002, it was abandoned all over the United Arab Emirates and all over the GCC. So there is really a great collaboration between GCC countries in combating tobacco consumption and also to raise the awareness. So this is a session where really effective mass media has a big role in reducing the prevalence of the tobacco consumption, and same time improving the quitting and improving the healthy lifestyle approach. So both of our colleagues, they complement each others, and we have the international thoughts, and we have now the national or the GCC thoughts, how to do best campaign and what are the alternatives and what are the modules we can use and it shows that it is not only one module, but different modules we need to think about. So I with your permission, I have to go to our discussant colleague, Dr. Mohammed Al-Yamani and Dr. Jamil Akhanji. But before I start, I would like to give you another report. I am a reporter today. The report, but sadly it is a report of is not good things, but anyhow, it is a report that encourages us as a policymaker and a commitment people towards a very noble sake. This is from UN, and it was advertised, or it was published in the Al-Iqtisadiyya newspaper in Saudi Arabia. It was in 2009. And it was mentioned that the recent report of the UN about tobacco consumption in youth, adolescent, that Yemen is the first in the Arab countries and internationally. Yemen is the first in Arabic countries internationally, and the second to this one is Lebanon. Okay. And at the GCC level, that Saudi Arabia is the first, the 17.5 of the youth, they are smoking, and the Kuwait is, the Saudi Arabia is 22, and Kuwait is 17.5. Emirates is 12.3, she said 13%, and Bahrain is 10.2, and Oman is 7, and Qatar 6.2. And it was shown that from the report of the UN that the prevalence of tobacco consumption in youth in male, it is around 29% in the male side. And it also said that the prevalence is increasing from 13 to 15. So 13 is the lowest, then 14, then 15 is becoming the highest prevalence of smoking in these countries. So with this data and with Dr. Muhammad Al-Yamani and the presentation from the two eminent speakers, you are a person of charitable organization. How do you think, what is the best way to tackle these issues? This is now the government, they did a lot of work, and there is a charitable efforts in USA and in UAE, but you are a person of, as a chairperson of a charitable organization or society in Saudi Arabia. How do you feel and how can we tackle this issue from your perspective? Thank you so much.
Thank you very much. Well, first of all, I would like to thank Emirates Center for the invitation, and special thanks to Dr. Tawfiq because he's the one who contacted me first about drawing my attention to this important meeting. Well, first of all, we know that culture is an important component, and especially in smoking, and I will highlight several points that indicates that it is more important even than other diseases. And secondly, one has to state that prevention of smoking, it's the most effective intervention by all authorities who know about smoking, definitely. And of course, we would like to state that most of the efforts are directed to encourage people to quitting, which is a very noble cause. However, I believe that prevention of initiation of smoking in non-smoking population is far more important than, it is still important to encourage current smokers to quit. However, in my opinion, it's more important to prevent recruitment of new smokers. We have tried several campaigns in the Kingdom of Saudi Arabia through our NGO, through NAQA. We succeeded in some. We didn't succeed as much as we hoped for in other campaigns for different reasons. And I think part of that, we need more coordination, more cooperation, and even more integration of our effort with the anti-tobacco program with the Ministry of Health. I am very pleased to say that we are coordinating with them at different levels. However, we hope in the future that we will get the NGO governmental sector to work in synchronization about this issue. I think in our societies here, in our culture here, in the Gulf regions, the involvement of officials, government, important figures is very important in any issue, and smoking is no exception. It is unfortunate that there is data to suggest that the rate of increase in female smoking is alarming, at least in Saudi Arabia. I'm surprised and happy as well of the rate of smoking in UAE of 0.8%. This is possibly amongst the lowest, if not the lowest in the world. And I hope it's a true number. Going back to mentioning about ambassadors, which Tawfiq mentioned this morning, actually we have NACA ambassadors amongst the school children, especially the high school, and some of the teachers. And this is an opportunity to highlight that for the past 3 or 4 years, the bulk of our efforts at NAQA was directed to the youth at schools. We have 2 major projects that we currently working on, both supported by our partners. One of them is a continuation of a 10-year program that we are coming into the 9th year in 2014. And for the past 2 years, our sponsor decided unilaterally, unfortunately, that we have to go solely to the schools. We were very pleased to the decision, and we are seeing results as reflected by the data that is suggesting that. Of course, spending on anti-tobacco efforts in our region, it's unfortunately very small and meager, especially at the NGO level. And what is spent by tobacco industry to promote their products represent an overwhelming amount compared to what is being spent. There is something that Dr. Tawfiq has worked on, which is the increase of taxes on tobacco. Unfortunately, we had only 2 increases in the past 15 to 20 years. And to tell you how companies are working, the first increase, the tobacco dealers in the Kingdom of Saudi Arabia, I'm not sure about the other Gulf countries, the GCC countries, they were told bluntly by the companies, we will absorb it, don't worry, do not increase it to the end user. And we were trying to convince our Ministry of Finance to increase the taxes, and until now we have very limited success, unfortunately. We hope that will change the picture, because it has been proven that increasing tobacco prices worldwide will have 2 proven results. It will encourage many people to quit, and it will recruit less smokers in the industry. There is a misconception about the donors in our charities. One of the consultants for one of our partners, he came, he asked us, are you treating smokers? Yes. We said, yes, we have to treat them ethically, economically, religiously. He said, stop. Religiously, you shouldn't treat them. I said, why we shouldn't treat them? He said, they came to the danger zone by themselves, so let them go. I said, no, this is, as a healthcare professional, it is my ethical responsibility to treat them regardless of whether they are smoking or not. Of course, religion is an important aspect, and as diabetes mentioned this morning, that it may affect the chances of marriage both for males and females. Somebody might be turned off or turned down, either a male or a female, because the other partner does not want a smoking partner. I think one of the major points that our colleague here mentioned, the seduction of tobacco industry. They have cigarettes for males, cigarettes for females, and cigarettes even for the youth. I think quitting is, I need to say this, quitting is very important, but I think most of our campaigns should emphasize on the issue of prevention of initiation of smoking. I have looked at some of the data that we have in the Kingdom of Saudi Arabia from our other colleagues in the NGOs and from Ministry of Health. There is a misconception about the quitters. The definition of quitters is anybody who comes to the clinic, he attends the program, and he leaves and he say, I'm a quitter. Internationally, you cannot consider them a quitters unless they are six months, at least 6 months, abstaining from quitting. I think companies are always inventing and coming back to us. For example, the images, some of the dealers in the Kingdom of Saudi Arabia, I don't know about the practice in other countries, they give as a gift a jacket or a cover for the cigarette packet just to hide the image that is doing. I think we have to take a lesson from drug control about our messages. We had a campaign against the use of drugs in the Kingdom of Saudi Arabia some years back. Unfortunately, the result of the campaign was a negative impact. There has been an increase in the use of drugs. So this highlights the quality of the message and what the message should say. Thank you very much.
Thank you, Professor. This is an excellent intervention. And I just would like to comment in, he mentioned so many issues, but before I give the floor for my colleague, Dr. Jamila, just to tell you how important the message. I went to the meeting for Minister of Finance Executive Board and in order to raise the tax in the GCC. So I opened the door, I pray a door prayer. I was very clean, smelled nice by perfume, and I opened the door to tell the message, this is the way we have to increase from 100% to 150%. So I just opened the door. It's almost a room around 10 meters by 8 meters. I saw a cloud. Then I make a joke. I said, it's going to rain. And then I said, I cannot tolerate. I am a risk person. I have cardiovascular disease, hyperlipidemia. Now I will have smoking, passive smoking. So I will have, it was the 5th time I was admitted to the CCU. So this, I will have the 6th time to be due to a meeting. Then they start smiling. And imagine all of them except one country refuse. So they said, no, this is, we cannot accept. So this is the way that when you want to go to the higher authority, how they really see the issues of raising the taxation, different from what we see as a health professional, okay? This one issue. Second issue I would like to say about the messages. I went in the conference in Jeddah. It was about healthy lifestyle conference about wellness approach. And imagine there was a session about smoking. So we finished and we went to go have a lunch, like after now. Huh? So we went to the, it's in the Intercontinental. So we finished the lunch. Then I walked with my colleague, Dr. Yasser Salama. He's a writer in the, he's a consultant dentist, and he's a public health person. He's a writer in the Uqad newspaper. And we are walking in the corridor, and I saw 5 Saudi young youth ladies. I looked at them. They are very nice looking and attractive girls, and they, yeah, my eyes. And in the first time I saw, it is thinner than my maswak, the cigarette, and it was green. And the way they smoked, I said, what is this? Where we are? In Saudi Arabia or what? I was shocked really first because I saw 5 ladies, they are smoking in the front of the old people. This is against our behavior. Second, they are young. They are around 25, between 20 and 25. They are still young. Then I said, Dr. Yasser, what do you think? Shall I go and advise them? Or they are like my daughters. I said, Tawfiq, you are from Riyadh. You don't know how to speak with people from Jeddah. I'll go. I said, okay, go. I said, go and speak. So I was waiting, and he went to them. Listen, my daughters, my colleague, and whatever, sister, he's speaking Arabic. يعني أنتوا عارفين الدخان. You know that the cigarette can make you more elder, and it will lead to breast cancer. So one young girl, she said, I have to speak in Arabic, so because the issue in Arabic. She said, Ya wad under ya wad.
Well, they told me, look, you get away from here or I'll kill you.
Get lost.
Get lost, and you boy, get lost. I let you get lost now, and.
Why I'm saying this one, sometimes if you want to advise, sometimes it's very hard to be accepted from the audience. So we need to, as he said and she said and Dr. Muhammad said, we need to, now we need to think seriously what modules and what intervention we should use with our adolescents and youth, especially in anti-smoking campaign. Now we, as they said, the MISC at the end and all are MISC. So now we go to Dr. Jamila. You are the spokesperson, am I right? The spokesperson of the Family Development Foundation. How do you feel or how do you evaluate the relationship between your foundation and with the government recommendation and resolution from the I mean, how can we empower organization like our organization to be an activist for such respected goal? Thank you.
Thank you, Dr. Tawfiq. Allow me, I'll comment on this part and respond to the questions while I'm standing for several reasons. In the name of Allah, the Merciful, the Compassionate, the praise be to the Lord and to Prophet Muhammad, allow me to greet you and to respond to the question while I'm standing in front of you as part of my respect to the audience. And I'll start from you and directly from you, and may God protect you after the heavy meal of carbohydrate. Some of you took a short nap and you have the right to do so, and with the presence of carbohydrates, and there is a kind of a downshifting of the brain, and then you need to activate it with an exercise to take more blood to your own brain, and then you come alert to listen to me, and then we'll do a kind take a kind of a deep breath in and out, and then activate these two, then wrap your these two parts of your chest, and then you will be alert to listen to me, and I'll speak in Arabic again for one good reason, that you can exchange your headsets, and then some of you will be awake and others
maybe you have a passion to it. Thank you. Thank you. I'm going to start from my colleague when he said
when he said that they started a campaign to eradicate smoking, but the results were negative, and I really thank you because you gave me a real start and beginning. And he said also we have to start with our own religion, and allow me to start with this point. And there are in specializations, in certain specializations, we have to employ these tools in our own campaigns. The reason that made me stand here was to speak to you through the right ear. The first piece of information comes from the prime ear, which is the right side ear, while the second one, or the secondary one, is the left one. So at home, in your lectures, wherever you were, whenever you give information for the first time, make sure that you address your audience through the right ear, so that it goes directly to the memory and be effective. This is a response to our colleague who said that the message should be effective, and this is one of the first tools of effectiveness. You make sure which ear it was conveyed through. And then my colleague said that the result was negative regarding the use of tobacco. I'm certain that there are some linguistic tools, colors and voices were giving a negative programming of the brain. Close your eyes, please, and imagine that you are in a very beautiful garden. This is an exercise. Those who are sleeping, please wake up and then you sleep again. Okay, well, open, then close your eyes, please, and imagine that you are in a very green landscape, a beautiful park with beautiful trees where you have green colors, flowers, sparrows, and imagine that you see a monkey over that tree, or a tree. See that monkey, and then never imagine that the monkey holds a banana in his hand. What happened? Never imagine that the monkey is eating a banana. Never imagine. Open your eyes. What did you see? You saw a monkey eating a banana. That's what I mean. When the message is clear from the teacher, the educator, or the politician, or a specialist, or the media person, or parents, the image should work in compliance with the mechanism of the brain, because the brain is the container that processes it and then it changes the behavior. That's we want to change the behavior. This is our purpose. All our work regarding with the policies, measures, programs, qualitative and quantitative programs, all these things and the campaigns seek to achieve the objective of changing the attitude from the health and social and future perspective, and even from the economic perspective. So the most important approach for men, the question that was imposed, that we should have an effective message in our own campaigns. There was a kind of effectiveness, but people didn't quit smoking. How can I lead them to quitting once I have a positive message to the audience that that person should have received it as I sent it from them? And in the first presentation, the speaker said that the comments on the ads, on the commercial ads, were positive, but they were not so effective to make them quit. So they did not receive the first concept or the message as was expected and planned. So where is the mistake? Where is the gap? Where is the gap in this message? Let's see. And 2 days ago, I saw Widad on TV in the local news. I was really happy to see you on TV. And through the implementation of the bylaw of the tobacco use, they interviewed some people, that is the stakeholders in this process. Two of those stakeholders were owners of coffee shops and shisha distributors. Mentioned one word. I couldn't sleep for 2 hours later on. They said that the decision had a negative economic impact and our business went down, our sales went down, and the cost is going higher, and the rent values went higher and higher. And so I'm talking about the value as a foundation, and as educators and scientists, we have to create a shared value in our own societies among all the individuals in consistency, with a high level of consistency. So when the economist and the businessman have the desire to build themselves economically speaking, but they should not have any damages on others. These are the teachings of Islam. No damage to you, no damage to others. And the second point about this consistency, thabat here, which means consistency in raising and activating the laws and regulations and the model. We don't have the consistency or a model for our children. As Dr. Tawfiq, he entered into the room of the decision makers and found a cloud of smoke there. So the first thing that you give to the child, and you take it from the model, from the pattern, from the brain works like this. And if that piece of information will have contradiction, the brain will take the easiest one, the closest one, especially those children who have problems. And once we will have the sense of responsibility, where is health sustainability? If I have a business, a profiting business, and I will never be accountable for the health of others, those who will be affected. So where is the value here? The second question, as for tobacco, I read the regulations, and at the regional and the GCC level and international level, there are many variations and gaps, a kind of inconsistency, and a kind of inconsistency, a kind of contradictions. Here they impose fines, and if you go to Europe, the same thing applies to drugs. For example, in Malaysia, the sentence is death. Here, 3 years, and in Europe, 3 months of imprisonment. So there is a kind of contradictions here. And in this forum, for example, we have educators, we have scientists, we have program designers and IT people and decision makers and policy makers. We have to take a real stride, a real step to send to the world. We are talking about globalization. Where is that globalization? We should have shared values at the humanitarian level, regardless of the ethnic background, culture, gender, age, sex, and other things. And when we have equal values, and the most important value in Islam is that when you do something, it is good for you, but when you misdo something, it is the result that you will have the consequences upon yourself. So in order to be effective in your own relationship, you have to improve the relationship with yourself. You have to have a self-esteem, not to be more egoistic, but to be more self-esteem person. And whenever the incentive, external incentive was, we were talking about external motivation. There is another thing which causes the behavior or the attitude. You either have self-motivation or external motivation, regulations, policies, laws, measures, prevention measures, and so on and so forth. And how about the internal motives? The internal motives, the making you say no for yourself. This is our own duty, and through the educational organizations, through family development foundations, we started, in fact, at our own foundation to address the elements of emotional intelligence and self-realization elements, so that one has the enthusiasm, the excitement, consistency, and continuation in the activation of values. I have so many things, but this is enough for you. Thank you very much indeed.
شكرا دكتورة جميلة ما شاء الله كلامك جميل من اسمك فربنا.
It's Jamila means beautiful, and it's really beautiful how you spoke, and it's really important to have a communication, how to send the message to the listener. Now we are 10 minutes late, but
we can take 10 minutes more to have some questions to our respected colleagues. So it is your turn, please. Yes.
Well, the chairman, sir, thank you very much. Appreciate very much of your kindness in allowing me to voice a few questions. And first and foremost, as a layperson, my due regard and respect to each and every one here and yesterday for your dedication and conviction into thinking of the social dimension that we are facing. Though that I have some reservation with regard to the term of reference, when we talk about interventions for a healthier future, I noticed that throughout it very much about the present syndrome, dilemma, problem that we could not overcome. That's quite sad, because we are not moving into the future, but we are currently, looking backward rather than forward. My question here with regard to Matt, well, you see the campaign when you talk about, too often we find that we took a wrong perspective at the smokers. For example, that, we are negative toward them. So the question is that instead of converting them, we created hatred. And instead of doing good reverse engineering and reverse psychology, we are provoking them. So in fact, results is not really good. Because you didn't mention about, the question is that in America is different positioning, but in the Middle East or in Islamic countries, the question of the spiritual marketing is not deployed very well. In other words, that question of humor, dimension is not to be seen at all. Because the question is that if you persuade, and then you come up with the right version of persuasion, bearing in mind, not compromising, because Islamic tradition and heritage forbid us on compromisation. But the question is that to convey something sound, beautiful, and worthy for them to consider, I think perhaps, for example, you look at children, does not cultivate their parent to say, if they're smokers, why not reversing it? So in fact, in a home, it is not done. Neither the wife did try their best to convince the husband that please stop smoking. But in a better way, in a beautiful way. I believe that's just what's lacking in the advertising world. Thanks a lot. So I would appreciate very much in terms of positioning.
Thank you so much.
Yeah,
I would like my colleague, if anyone would going to ask in short, in 5 seconds, and the answer in 2 seconds.
Yeah, so I guess if I have 2 seconds, I'm already done. I'll just take the one slice of what I caught in all of that. It is very important to when you're developing a campaign, you're really developing a campaign against tobacco and not against the smoker. There's no effort, no successful effort should be against a smoker. Most smokers want to quit. So a campaign should never try to shame a smoker. Or it's really that you're trying to highlight the health effects for them. So it should never, a campaign should be never anti-smoker. It should be anti-tobacco.
I think this is an excellent answer. Any question? Yes, Dr. Mahmoud Fikri, and you yourself, then Dr. Muhammad Yamani. Dr. Mahmoud Fikri here in the front, and you yourself.
Thank you very much, Dr. Tawfiq. First of all, thank you very much for all speakers. I really enjoyed this. To tell you frankly, to develop legislation for especially for tobacco control, it is not an easy job. It took us 10 years working with Dr. Awadad. Dr. Awadad, I always call her, she is a tobacco fighter, but she's always behind this, and then finally we got that. The other issue, when you want people to stop smoking, they should believe first that this smoking is a very dangerous for himself first, then for his kids. When he believes in this, then he will stop and he will not allow the other to smoke in front of him. The other thing, from the experience, the long-term investment in tobacco control and prevention, to invest in the younger children. Start from the school. Teach them about the hazard of tobacco as a proven cause for cancer. So from here, when they believe in this, when they learn that this is a cause of this, of the cancers, and then you will get a generation where they will not smoke at all. If we look at these, the companies always targeting the school age, especially 12 to 18 years, where they want them to be engaged in smoking. Because these people, when they are engaged in the smoking, they are very difficult when they become adult to leave, to go to the smoking. The adult, from the experience of these clinics, we notice that the adult, when he starts smoking, within 2 or 3 years, he can't get rid of it. But the other one, no. It takes longer time to convince him to take this. I think we should take this experience into consideration. Thank you very much for all of you, especially for Jamila also. She gave me some good knowledge about how to attract people to listen to you. Thank you.
I'll try to be quick. I mean, this theme has come up twice, and this is a debate that many have had. Focus on youth and try to prevent them from starting, or get the adults to quit. And it's probably, if you have the resources, it's not an either or, it's both. The only caution I'll say with youth prevention is if you spend much time with a teenager, you understand that convincing a teenager not to do something is very challenging. It's important to educate them from the young, but the kids that are most at risk of smoking are also the ones that are rebellious and are not listening to you for a lot of other reasons. And so it can work, but just keep in mind that you have to really think about and talk to those kids that are most at risk to figure out what messages will stop them. And on the flip side, cessation is very difficult because people are addicted, but they're also starting to get, when they smoke long enough, they're starting to feel the effects of smoking. So when you highlight the effects of smoking, it hits home. So I'm not necessarily contradicting you, but it's just a word of caution that the campaigns have to be developed very carefully. And to not talk to the kids that aren't at risk. You need to focus your message development on the kids that are most at risk to see what is going to change their mind. Not the kids that, that you preach to the converted, as we say.
Thank you so much, Dr. Matthew. Yeah, yourself, please. Good self.
Yeah, I'm Patricia. Thank you for the very inspiring talk, and especially to the Emirates Media Center for hosting such a valuable event. Shisha, how bad is it? Because you see in many of the cafes, shisha going on in full swing. And it is like passive smoking also, because they harm themselves and also the rest who are, especially they have it in the buildings and in the ground floor. And quite a number of people are being harmed by that. So can you please give me an explanation on that? Thank you.
Before I give Dr. Matthew, the most expert person in the GCC on Shisha, the one who did a lot of study, is His Excellency, the ex-minister of Qatar, Professor Dr. Hajar bin Ali. He published a lot of articles, and one of the articles showed that one Shisha is equal to 20 packets of cigarette. 20 cigarettes. But the carcinogenic and the effect of shisha is more than the smoking. This is what he came out in his journal. Is a Qatari journal, is about heart news. If you go to the Qatari Foundation, Hamad Foundation, you will find a lot of research on that one. Otherwise, I'll ask Dr. Matthew if they have any comments. In 1 minute, please, because we are late.
Okay. Regarding shisha, of course, shisha is much dangerous. And in different aspects, as Dr. Tawfiq stated, it is the research in shisha, it is good, but we need lots of research in that. But the available research proves that in shisha, the smoker is exposed to lots of carcinogenic and also to high concentration of carbon monoxide. They are using cigarette, they will not be exposed to the other. There is one, nobody will say cigarette is better than shisha or shisha better than midwah. But the awareness of the people, the customer also, they are fooled by the marketing people for this stuff that it is all herbal, it is a fruit, it is whatever. So it is not, because while they are cooking it and preparing it, it's tobacco added with glycerin and lots of fermented fruits. And the way to use shisha is adding the dangerous, because they take it in a very deep breath. So they let the carbon monoxide and the dangerous and the carbon go to the deepest part in the lung. More than that, they are exposed to a lot of infectious disease more than the other type of tobacco use. So shisha is very dangerous. I I have a comment regarding.
Dr. Wadad.
خلاص my minute?
Yes.
Okay.
Dr. Matthew, please.
I think you both covered it quite well.
Okay. What I will do before ending this session, I'll give Dr. Jamila 1 minute, Dr. Muhammad 1 minute, Dr. Wadad, Dr. Matthew 1 minute. I will stop the microphone.
Yes, بالنسبة للمراهق.
As for the adolescents and or those who would like to quit smoking must be part of the solution and not part of the problem. So we get them involved in the setting solutions, asking adolescents, women to take part in this. And as for the strategies to be used in campaigns, such as the use of the logo, I greet the designers of this logo because they use the spectrum that would affect human energy, all these beautiful colors, and I think they are very specialized, and I hail them there first. These are the colors that should be used in raising the energy and the treatment. As for the low voice or the sound in the brain will affect the subconscious, and if you receive a message, and it was tested in Britain, I think, and Britain is now has stopped all low voice or low sound messages because it affects the subconscious. In some supermarkets, if you send such a low sound, you may reduce the possibilities of thefts in supermarkets by 37%, and therefore there are other means in the field of psychological engineering or neurology that would help us solve these problems. Thank you, Doctor. Thank you, Doctor. Dr. Mohammed Al-Yaman.
1 minute.
I have to be very quick. First of all, the effect of smoking, banning smoking on business has been challenged in many countries, and it failed miserably. I mean, there is no impact. Secondly, of course, we do not animate the smoker. There was a hashtag recently in Saudi Arabia. What advice you will give to the smoker? And because of some cynical comments, I've asked the people who are involved to stop it because we don't want to animate the smoker. There was an example of a wife effort to stop her husband from smoking, and that was when he is coming to the bedroom, she asked him to take a shower, change all his clothes before getting into the bedroom, and she succeeded tremendously. Strategies, okay. Quality of research on shisha, unfortunately, the quality of research and the quantity is very little, and I am sad that we have exported shisha to the Western world, but I'm happy that some quality research will come out of it, and that's my final comment. Thank you very much.
Thank you, Dr. Muhammad. Dr. Wadad, well done, well done. I am sorry for this.
Thank you. I just have one final comment regarding the when Dr. Jamila stated that she feels sorry for these people who was investing in shisha and saying that from the money of the shisha, I am growing up my children. Of course, we have to know that when we put one step, the tobacco lobbying put 10 steps. So we have to protect our nation. I know it is investment, I know it is an income, but still these people, this is not the first time they know about our efforts. 10 years to reach to this point. So I think we success, and by the time they will know, when we start to reinforce the smoke-free environment in Dubai, closed area like the malls, we have a lot of resistance, and people think they will reduce their even sales, but it was the opposite. Thank you.
Thank you, Dr. Wadad. Dr. Matthew, you have the floor, please.
I'll be very quick. Two things. One, I've shown that investments in tobacco control are effective in reducing tobacco use. So it is a strong investment. It's a good investment. The other thing is I sense a lot of passion for this topic, and the panelists are very knowledgeable. I would just like to end with saying I hope that we can keep this conversation going. I think we can learn a lot from each other moving forward.
Thank you.
Thank you very much. I have 1.5 minutes to end up this. First of all, let me thank the scientific committee and the people behind this very excellent conference, especially this session, because I think this session is a very crucial session in whole NCD programs. And really, I respect them so much because it touched the mass media and also touched the tobacco issue. Also, I would like to thank all my colleagues, the eminent speaker and the discussant, who really make this session very rich. My appreciation and gratitude to Dr. Suwaidi and Dr. Holden and all the people who really make this conference is a reality, and it is an added value for the GCC noble sake. And I think all of us, we are doing a noble issue. We are working together for the health of the nations in the GCC. So on behalf of the Health Minister Council and the Executive Board and the rest of our people in the GCC countries, I thank this center, the Emirates Center for Strategic Studies and Research, who really bring us all together for a noble sake, which is health of the nation. May Allah bless you all, and I'll give the floor for the closing remark, Dr. Holden, who is going to deliver. Yes. So the closing remark. Thank you so much all. Well done.
Thank you very much, Dr. Tawfiq, for chairing and moderating this session. And this first part was regarding the recommendations of the conference, as a committee was set up consisting of the speakers and the participants in this seminar or this conference. And the following is the final recommendations reached by the committee, starting from the Emirates Center for Strategic Studies Research to achieve and to raise the levels of humanitarian services in the United Arab Emirates, including health services, and enhancing cooperation among the GCC states in this respect, and in compliance with the decisions taken by the leaders of the GCC states, members of the Supreme Council, in the 32nd session held in December 2013, by adopting a unified plan to eradicate non-communicable diseases. The Emirates Center for Strategic Studies, in collaboration with RTI International, United States of America, organized the first Arabian Gulf Public Health Research Center interventions for a healthier future during the period 21st, 22nd of January 2014, inviting a number of experts in the field of health care from the GCC states and other nations. The conference dealt with the following measures as preventive measures for the cardiovascular diseases and the economics of obesity and the NCD, obesity, and massive media campaigns for public health and the anti-tobacco campaigns. And the recommendations committee met and collected the recommendations suggested by the participants, and whether oral or written, and came to the following. First of all, for the research and statistics, the committee requested the GCC members to prepare the database for the reasons and causes of death and the risks related thereto, and sustaining them and updating them, requesting the ministers of health to establish a grid in the GCC states, a network in the GCC states, to study the health systems regarding the non-communicable diseases and publishing the research in this field. 3, calling upon the ministers of health also to adopt the health systems based on national database for the determinants of public health, and conducting more studies in the field, and in order to improve the standards and the sustainable development of the Gulf Plan to eradicate the NCDs, providing full support and budgets. All countries are requested to intensify their budgets regarding the awareness and the prevention of NCDs as part of the financial and logistics support in order to expand the campaigns of controlling these diseases. Second, to stress the fact that combating these diseases is a national campaign, and accountability to be taken by all government organizations as part of the prevention of chronic diseases. 3, to qualify health leaders in the field of economics of non-communicable diseases, and to continue research in the field of public systems, and to prepare health models, unified health models, to be measurable and containable, and also to provide how the means of prevention. The 3rd%, the national plans, first of all, to encourage integration among research centers and academics in order to enhance the systems and initiatives to develop non-communicable diseases and chronic diseases at different levels regarding the health services and how to sustain them. 2nd, to stress the fact that these effective measures shall be taken regarding the public health and programs in order to enhance preventive medicine and to improve the circumstances surrounding these services, to enhance the primary care units, and to enhance early detection of diseases, and to improve the quality of services through raising levels of infrastructures and capacity building of human capital working in these facilities, and to provide them with diagnostic methods and instruments in order to enable them to work effectively and efficiently with the non-communicable diseases. The 4, to enhance partnership among different sectors, among the ministries of finance, universities, NGOs, civil society, and private sector in order to raise the level of services. 4, to develop the human capital in the field of health public, including 1, enhancement of the medical staff and communication skills and the comprehensive view and perspective of the patients. 2nd, to enhance the capacities of the health workers by providing continuous education for all categories of health workers in the field of prevention, diagnosis, treatment, and integration of the non-communicable diseases, media and awareness. It is necessary to use the modern technologies and social networks to raise levels of awareness regarding the raising of levels of education as they are free and cost effective, and also enhancement of lifestyles or healthy lifestyles. For example, the prevention of watching smoking on TV, plays and other movies, and also to enter into partnership with the Emirates Center regarding holding this conference on annual basis to provide solutions and suggestions with the review of any progress that could be made in the implementation of the GCC strategic plan in implementing this plan. 2nd, to have a recommendation to set up a committee of advisors in the GCC states regarding the contribution to having frameworks for the future perspectives to develop public health services in these countries as per the approaches adopted by the Emirates Center for. And finally, the Director General of the Emirates Center for Strategic Studies and all the participants in this conference raised their own gratitude to His Highness Sheikh Khalifa bin Zayed Al Nahyan, the President of the United Arab Emirates. May God protect him, and to His Highness Lieutenant General Sheikh Mohammed bin Zayed Al Nahyan, Abu Dhabi Crown Prince, and Commander-in-Chief, Deputy Commander-in-Chief of the Armed Forces, and the President of the Center for their generosity and hosting this event, and hoping that all the participants and speakers made use of the exchanges for the benefit of the GCC nations and the enhancement of cooperation. And thank you. God bless you. That was the text of the recommendations, and now we come to the final address of the Director General of the Emirates Center. As a conclusion, in the name of God, Your Excellencies, ladies and gentlemen, Assalamu alaikum. It gives me the pleasure at the end of this first Arabian Gulf Public Health Research Conference, which held the slogan of interventions for a healthier future, to express my gratitude and appreciation for all researchers, participants, and the audience for your own endurance and your great efforts and your presentations and your serious discussions over the last 2 days, shedding light on many of the dimensions of this cause, which is considered one of the our own priorities in the GCC states, and I would like to avail myself of this opportunity to express my gratitude to the staff of the RTI International in their cooperation with us in organizing this event, especially His Excellency Dr. Wayne Holden, the CEO of RTI International in the United States of America, and Mr. Tim Gable, and the officer, the Vice President for the official and environmental and social services, hoping that this cooperation will continue in studying and examining the issues related to the world issues in order to provide prevention and health security and public health services for all the nations of the region and the world. It gives me the opportunity, the pleasure also to extend my gratitude and appreciation to His Highness Sheikh Nahyan bin Mubarak Al Nahyan, Minister of Culture, Youth and Community Development, for paying attention to all our conferences held here in this center, and his personal attendance on continuous basis. Ladies and gentlemen, your own conclusions and recommendations in this excellent conference and the draft resolutions to be taken are very significant, and we hope that they will be taken by the official channels to be translated into policies and practical projects on the ground in order to enhance the reality of public health and the development of sustainability of such projects, especially that your recommendations were the outcome and the epitome of different scientific approaches and perspectives that were shedding light on and focusing on how to reach a best intervention for a healthier future and the prevention of chronic diseases, and especially those of obesity, cardiovascular diseases, and other and tobacco use, and how to prevent them and how to treat them as per the latest developments in the world. Ladies and gentlemen, we were really pleased to have read your own recommendations and your own papers that focused on the necessity of having an integrated strategy and policies that would comply and face the incurable diseases and the other chronic diseases that threaten us and threaten humanity in general. I thank you while you are our guests in the United Arab Emirates, and wishing you a very good stay in our own country. May God bless you, and thank you, and peace upon thee all. Thank you. Waiting for you in the second Arabian Gulf Public Health Conference. Thank you very much. God willing.